Good evening, everybody joining in India, and good day to all of you who have joined from other parts of the world. I welcome you all to the second session of virtual clinics from Institute of Liver, Gastroenterology and Pancreato-Biliary Sciences at Sir Gangaram Hospital. Yesterday, we had advances in hepatology, and today we have specifically chosen advances in luminal gastroenterology, coupled with a very interesting talk by Dr. Abu Dai on non-surgical weight management strategies. So the format is that we will have total of 5 sessions. Each session will be for 35 minutes. Amongst those 35 minutes, 20 minutes will be for the speaker who is going to talk of recent advances over the last few years regarding that particular topic. These advances have to have the clinical relevance, and after the presentation, the moderator of the session is going to discuss these topics threadbare. Using his own clinical perspective, he's going to involve the panelists for discussion on the various aspects of what has been presented by the speaker. So similarly, once we end up 4 or 5 sessions today, we will have the summary of the day. So without taking much of your time, may I request Dr. Rakesh Kochar, who is the moderator for the first session, titled Advances in Functional Bowel Disease. Dr. Rakesh Kochar, please.
Thank you, Dr. Arora. Well, for this beginning of today's sessions, we have the first talk on functional bowel disorders, and Dr. Usha Datta, who is a professor of gastroenterology at the PGI Chandigarh, is going to deliver this talk. She has deep interest in luminal gastroenterology, and you all must be knowing that she has been trained earlier in Australia and then lately in Canada, and she has in-depth knowledge about functional bowel disorders, which she has reviewed for us, and she'll be sharing what has transpired in the last 5 years, and have the concepts changed or not, and how do you deal with it. May I request Dr. Usha Datta to start her talk? Dr. Usha.
Thank you, sir. Thank you. Good evening to everybody. At the offset, I must congratulate Dr. Anil Arora for putting up such a good scientific program amidst all the COVID issues. So I'll be discussing on recent advances in the functional gastrointestinal disorders. Functional GI disorders is basically a bag of chronic unexplained gut syndromes, a set of patients whom we don't like particularly seeing again and again in the OPD because they just don't get better. Based on symptom-based classification, Rome 4 has classified it, and there are 24 groups of disorders, the commonest being functional dyspepsia and irritable bowel syndrome. Not particularly possible to cover the dyspepsia as the prototype and which have last 5 years. No obvious structural or pathological cause for this disease, that is what I understood, and it affects quality of life, healthcare burden, and cost of treatment, and does not affect survival. Symptomatic treatment is largely ineffective. So functional bowel disorders is a combination of abnormality, pain, diet, gets aggravated by diet and may respond to dietary changes. There is no obvious structural disease, no pathology can be identifiable, and there is also psychiatric comorbidities. So the prototype we'll take here for discussion is functional dyspepsia. Dyspepsia means bad digestion in Greek. Usually any upper GI symptom for more than 4 weeks is considered as dyspepsia. The prevalence is about 30%. 5% of them seek consultation, especially if they have psychiatric comorbidities. And that is the reason we have made a very strong association between anxiety, depression, and dyspepsia. It affects quality of life, cost, and healthcare burden, as already said, and fortunately is not associated with increased mortality. So in uninvestigated dyspepsia, after we do the initial round of history examination and investigation, we are able to separate them into organic and functional. Functional comprises 70% of the dyspepsia. Earlier it was called as non-dyspepsia, now it's called as disorder, the brain-gut interaction, and today I will show you brain interaction rather than brain-gut interaction. The organic dyspepsias can be related to GI or non-GI causes. So the cardinal symptoms of dyspepsia are 4: epigastric pain, epigastric burning, postprandial illness, and here pain syndrome usually also can happen in the empty stomach. However, the postprandial distress syndrome is meal-induced. Bloating, belching, nausea, and vomiting are also other than persistent should alert you to the possibility of gastroparesis, and it is not a usual common symptom of dyspepsia. Functional dyspepsia by Rome 4 criteria is defined as bothersome dyspepsia lasting for minimum 3 months duration with an onset 6 months back, with a combination of these 4 symptoms: postprandial fullness, early satiety, lasting for at least 3 days a week, that is considered as postprandial distress syndrome, and epigastric pain and burning minimum once a week is considered as epigastric pain syndrome, and there is no structural disease on endoscopy. So we have to understand that endoscopy has become important in excluding organic diseases before we make a diagnosis of functional dyspepsia. We'll come to it as to who are the ones who need an endoscopy. So we know that epigastric pain syndrome as well as postprandial distress syndrome, there's considerable overlap of about 35%, and GERD and IBS can be also associated with these conditions. What has been the paradigm shift? This is the focus of the lecture today. The pathology does not rest in the stomach primarily, it now possibly rests in the duodenum. The second thing is, it is not just a motility disorder starting from the muscle, it is actually arising from the mucosa. The mucosal inflammation is indirectly causing muscle abnormality and motility changes. We did not identify any particular bugs, so we thought it is not related to bugs, but it is the mucosa associated microbiota which drives this inflammation sitting in the duodenum. So this is the third paradigm shift. The fourth paradigm shift is that every time we thought it was a person with a psychiatric problem or a psychological issue or child abuse was the one who was presenting to us with dyspepsia, now it has been realized and fairly convincingly understood that it is the enteric nervous system which is driving the inflammation and communicating with the CNS. So the seat of the pathology is not the CNS, it is the enteric nervous system. The next understanding is that it was usually symptom-based therapy. So Rome 4 and all have been symptom-based therapy. And if you have realized that symptom-based therapy really doesn't benefit patients for too long, patients keep coming back. So this has changed to target-based therapy, and I'll discuss what are the targets. And so it was usually an algorithm-based treatment. You club patients into one set or the other and treat them accordingly. But now it is increasingly realized that it is personalized care. So these have been the 6 shifts in the nuances of dyspepsia. So problems in the stomach, we needed to look beyond. Here it is the mucosa associated microbiota, mucosal permeability issues, mucosal inflammation, and altered duodenum. So the duodenal microenvironment, you see here it's normal looking duodenal villi, and here there is duodenal barrier defect, and duodenal contents have changed, and there is dysbiosis which is now causing increase, go and cause immune activation and stimulate the local neuronal systems which affects the muscle, and also these mediators get into the bloodstream and cause a systemic kind of an inflammatory state. So this is where there has been a shift. There is sufficient evidence that there is increased mucosal inflammation in the form of eosinophils, mast cells, CD4 positive T cells, CD8 positive T cells. There is also increased mucosal enzymes in the form of tryptase, histamine, and serine protease. And there is decreased mucosal mRNA expression in patients with dyspepsia as well as IBS. Also in the bloodstream, there is increased cytokine markers as well as gut homing lymphocytes are increased. On histology, we find that there is increased amount of eosinophils. In adults, the cutoff is 22 eosinophils per 5 high power field, and in pediatrics, about 112 eosinophils per millimeter square. So increased amount of duodenal eosinophilia has been seen in the last 4-5 years of publications. And it is the eosinophil which drives the inflammation. It stimulates the mast cells and further histamine is released. This stimulates the local nervous system, which affects the local motility, which causes the symptoms. So from mucosa associated bacteria, increased permeability, stimulation of the antigen presenting cells, the Th17, which further stimulates eosinophils and mast cells, and this cycle goes on, and this is associated with a state of chronic low grade inflammation, which is not just lymphocytic, it has eosinophils, mast cells and lymphocytes. So we have understood that the mucosa is driving the whole process. So this is mucosa associated bacteria, pathogens, allergens, bile acids, which triggers eosinophil lymphocyte mast cells, chronic inflammation, which further reduces mucosal integrity and increases neuronal hypersensitivity. And this translates into visceral hypersensitivity, which we all know is an essential part of functional bowel disease. The resultant altered motility is what the patient comes to us, and we have always, that is why thought it was a motility disorder, but actually it is driven by the mucosal pathogen. So it is the mucosa and not the muscle. Second is microbiota. We thought had no role, but actually seems to be the driver. H. pylori has a significant role. Duodenal flora, the amount, the nature, the proximity to the duodenal epithelial lining, and the invasion, all of them have been found to be associated with symptoms of functional bowel disease. Post-infectious functional bowel disease and IBS are now well-recognized entity. And in both these conditions, also small intestinal bacterial overgrowth has been recognized. So if we look at H. pylori and dyspepsia, I have just one slide on it because we have discussed this on previous occasions. 40 to 60% of functional dyspepsia have H. pylori gastritis. In India, maybe a larger number. And 17 RCTs, the meta-analysis shows that the number needed to treat is 14. A recent randomized control trial shows that the number needed to treat is 8. And those with EPS responded better to anti-H. pylori therapy. So overall, there is more benefit than risk for treating H. pylori if you find in patients with dyspepsia. And according to Rome 4, we have to exclude H. pylori before we label a patient as dyspepsia. So the benefits are in the form of reduced symptoms, reduced gastritis, and also decreased risk of HP related cancer and decreased SIBO. But the risk is it can increase antibiotic resistance and decreases mucosal diversity of the bacteria. A recent study has shown that if they had profiled all the duodenal bacteria using 16S and found that there's increased streptococcus and decreased Provitella, and the higher the amount of bacteria, lower the quality of life. So this is a very important study which was published recently in Gut, saying that mucosa associated bacteria, the amount is inversely related to quality of life. Next comes the entity of post-infectious functional dyspepsia. In an outbreak of about 2,400 people in the year 2000, they were followed up, and the odds ratio of developing post-infectious functional dyspepsia was 2.3. That means somebody who has had gastroenteritis is 2.3 times at higher risk to develop functional dyspepsia later in his life. And the risk factors were women, smokers, patients with premorbid IBS or anxiety symptoms, those who had prolonged diarrhea, and those who had associated abdominal cramps. And there is a recent meta-analysis of over 9,517 patients. 909 developed functional dyspepsia. That means about 10% develop functional dyspepsia. The OR again being about 2.5. And the organisms implicated were Salmonella, E. coli, Campylobacter jejuni, Giardia, and norovirus. So, and in these patients, when they did the endoscopy, they found excess of duodenal eosinophilia. So in post-infectious dyspepsia, the excess of duodenal eosinophilia is a marker in the duodenum. So what does post-infectious dyspepsia do? It sensitizes the duodenum to further increase in permeability and exposure of bacteria, and causes local dysbiosis, which continues and perpetuates the local inflammation, and the release of the mediators from the local enteric nervous system results in constant anxiety and depression. They have found in community studies that gut abnormality precedes anxiety and depression in about 50% patients, saying that gut may be the driver rather than the brain. So the risk factors for post-infectious dyspepsia are adverse life events, depression, older age, female gender, smoking, as well as abdominal cramps, bloody diarrhea, C. jejuni producing elongating toxins, so more severe disease, a pre-existing pre-morbid condition which can predispose to constant inflammation and lack of healing, and as well as evidence of mucosal lymphocytosis and EC cell hyperplasia at 1 year. So all these things are risk factors for subsequent development of post-functional gastrointestinal disorders. In a recent study, in an abstract in AGA, it has been shown that 26 patients with functional dyspepsia, when they did the biopsy, they found duodenal Veillonella abundance, and this inversely correlated with delayed gastric emptying time. So higher the amount of bacteria, higher was the lag time for the stomach to empty. Recent studies have also shown that there's increased SIBO in patients with functional dyspepsia, though it is more often seen in IBS rather than in functional dyspepsia. Duodenal mucosal permeability has been shown to be increased. So though the duodenum looks apparently well on white light, when we do studies with confocal laser microscopy, we find that there is a leak of this contrast. You give fluorescein intravenously, this is a normal looking duodenum, but here there is a leak of contrast into the lumen. So intravenous contrast is leaking, suggesting that there is a barrier defect at these points, which can be highlighted here. So these are the sites for the toxin and the bacteria to again gain access into the system. Bile acids also seem to play an important role, and here you can see that the green rectangle is the primary bile acids. Normally bile acids are secreted from the liver and in the after conjugation, so the yellow bar suggests that there is conjugation and there is very minimal secondary bile acids. But if there is duodenal bacterial overgrowth, the bile acids get deconjugated, so now the hydrophilic bile acids become hydrophobic and cause mucosal injury. Also, the bacteria can convert the primary bile acids into secondary, which further increase the leakiness of the gut. So deconjugated secondary bile acids are bad for the gut, and that is what increases in patients with functional dyspepsia. The duodenum seems to drive the symptoms. How? It was interesting for me to learn as I reviewed this thing. Duodenal acid exposure, when the duodenal mucosa is exposed to acid, it decreases gastric emptying, it decreases fundic accommodation, and it increases TLESR. We know that most of our patients with dyspepsia have associated symptoms of reflux. Some may not qualify to definite GERD, but definitely have increased reflux, and they also has postprandial fullness. And increased duodenal mucosal permeability also may present with pain and visceral hypersensitivity. And thirdly, duodenal eosinophil activation because of the acid is associated with food-related symptoms. So this is how duodenum may be driving the symptoms in dyspepsia. So the emerging targets for treatment are, we knew that we had all these targets earlier, that is central modulating agents like SSRIs as well as tricyclic antidepressants, and you have peripherally acting neuromodulators like tricyclic antidepressants. We used to use PPI to inhibit the gastric acid. We used acosamide to relax the fundus, and we used prokinetics to improve the gastric emptying. So we were all acting on a symptom-based approach. So now if we look at the defect in the duodenum, we can modulate the bile acids by using UDCA and bile acid sequestrants. You can reduce the dietary trigger by taking off things like milk, gluten. We'll come to that later. And then we have probiotics can be used to change the flora. Antibiotics for a short while can be used for changing the flora. And you can use H. pylori eradication to remove the H. pylori, which is in the stomach, which is increasing the acid production, and also emerging role of antihistaminic agents in the treatment. So here we have the emerging targets, and those are H1 and H2 antagonists. All of us have realized for a long time we have been treating them with cimetidine and famotidine and rentidine with decent response. But actually these were non-selective histamine blockers, and they must have been also acting on this eosinophils and mast cells, which we never realized. And now they are again coming back into picture of using H1 and H2 antagonists. Leukotriene 1R antagonist, as well as we realize that a lot of patients with long-term PPI have intestinal dysbiosis, and hence antibiotics and probiotics may have an emerging role in treatment of dyspepsia. So the previous therapy was the approach. The current approach was self-reported symptom, a diagnostic workup to rule out organic disease, and trial and error treatment by which the patient kept on going in this cycle of repeated endoscopies and up and down to the hospital. But if we do a personalized treatment approach in which we analyze the patient's symptoms, assess his risk of organic disease, see whether he has had an infection which precipitated it, understand the disease burden, his quality of life, and his nature of symptom, and make a risk-based diagnostic workup, and then do a structural assessment as whether it is the brain gut or the gut brain which is driving the thing. If it is that, then we can use CNS neuromodulators, or if it is inflammation which is driving it, then you use immunomodulation. If there is a pathobiome defect, that is the microbiota is abnormal, then we can try antibiotics, probiotics, diet, pre and probiotics, symbiotics. So this may have an important role, emerging role in dyspepsia. GI function, we can modulate it by handling the motility issues. So by understanding the pathophysiology, we can give targeted therapy. So how to evaluate? I will just quickly go over it given the recent understanding. So when we have a patient coming into the OPD with dyspepsia, we assess the symptoms, the severity and the nature, and see whether there are alarm symptoms, see whether there are any suggestions of systemic diseases like hypothyroidism, congestive cardiac failure, or any other endocrinopathies, diabetes. Look for drugs which can cause dyspepsia, especially NSAIDs, ecosprin and all that. But it's important to focus on their diet to understand whether gluten or milk or fatty food, what is precipitating their thing, and their timing at which they're taking their meals, because that's important. And then whether there was any GI infection which is driving the inflammation, any recent history of acute gastroenteritis in the past, in the last 6 months, 1 year, and what are the stress factors. So we do a quick physical examination, see whether there's obesity, whether there's any anemia, see whether there are cervical lymph nodes to suggest a malignancy, any acanthosis nigricans, assessment of abdomen for any tenderness or any lump, any ascites or any signs of systemic disease like hypothyroidism. We do a quick routine investigations, look for anemia, especially to suggest celiac disease, malignancies, peptic ulcer disease, or any inflammatory process. Look for renal failure, look for liver abnormalities for pancreaticobiliary causes, look for thyroid abnormalities, look for diabetes. In the stool, look for H. pylori antigen, giardia, or any features of GI bleed, and on ultrasound for any pancreaticobiliary causes. Next is who needs endoscopy. Those definitely with alarm symptoms need endoscopy. The age cutoff for India may be slightly lower than the West. So it is age of 60 years in the West. In India, we have to consider whether it should be 40 or 50 or 60. If we follow the Japanese and the Korean guidelines, it is younger, that is 40. The Western guidelines say 60. We don't have data in India, but one data from Dr. Jayanti's group has shown that the average age of CA stomach in India is about 43 years. So I think 40 years may be a good cutoff for our country, but we need more data. Any patient with GI bleed, anemia, dysphagia, persistent vomiting, unintentional weight loss, family history of gastric or esophageal cancer, a palpable lump or lymph nodes or imaging abnormalities, NSAIDs or aspirin. If any patient is having any of these alarm symptoms, they merit an endoscopy.
Dr. Usha will be time. We just look at the time, please.
Yes, another 3 minutes I'll finish, sir. So upper GI endoscopy is a good opportunity to pick up early gastric cancer. And as the approach to investigation in this situation would be a quick history examination. And if they are, we are planning for endoscopy, then we look for H. pylori or look for organic dyspepsias. And if we do not have any alarm symptoms, we do non-invasive testing for H. pylori associated dyspepsia. If both are negative, we label them as functional dyspepsia. And usually on endoscopy, it is important that apart from antrum, we also look at the duodenum. And I have added this duodenal biopsy in all these patients, apart from the standard biopsies which we do for antral gastritis. And it is a good opportunity for us to pick up early gastric cancer, especially by using NBI, and look for other associated abnormalities on endoscopy. As I said here, it's good to pick up any features to suggest gastroparesis or any features of gastric outlet obstruction. So only 70% of them, most of the people have normal endoscopy, and it is important to use validated RUT kits. And it is interesting to see that most of our patients used to come back with duodenal biopsy showing increased inflammation, which we didn't know how to interpret, and now we know how to interpret that. So the targets for treatment, I will finish with this slide, is anti-H. pylori therapy for if you find H. pylori. If there is acid, we use PPI and H2RAs. If there is dysmotility, prokinetics are effective. And if there is evidence of hypersensitivity, we use tricyclic antidepressants. And if there is psychiatric comorbidities, we use tricyclic antidepressants, SSRI, and psychotherapy. And if there is duodenal inflammation, there may be an emerging role of antihistaminics and Montelukast. With this, I come to the end of my presentation.
Thank you. Okay. Yeah. Thank you, Dr. Usha, for extensive review of topic of functional dyspepsia particularly, and something which affects the large number of patients. In fact, probably the largest number of patients in the outpatients department will be functional bowel disorders. So we Rishabh.
Can we butt in then?
Can I have a few questions?
Yeah.
Yeah, we can.
Yeah, ma'am. Do you do these duodenal biopsies routinely or in a subset of patients like post-infectious functional dyspepsia or the patients where there is suspected non-celiac gluten sensitivity? There was a paper recently by Professor Taylor which showed that NCGS and dyspepsia may be related through this common mechanism of duodenal eosinophilia. So is duodenal biopsy a routine or it is done in selective patients?
Dr. Sanjeev, that's a very important question. Every time when I was doing endoscopy in these patients, I always noticed some early abnormalities in the duodenum, especially when you put on the NBI. So when we used to take biopsy, we used to find a lot of inflammation there. We didn't know earlier how to interpret that. Apart from post-infectious dyspepsia, a large percentage of functional dyspepsia have duodenal eosinophilia. I think that has been an underestimated and under-recognized entity. So once we are doing an endoscopy, it may be a good idea to take a couple of biopsies from the duodenum and also sensitize your pathologist about that.
And in case you find abnormal eosinophils, say more than 22 per HPF, so would you routinely put them on like drugs like Montelukast?
Yeah, so the data is only from pediatric population where they have tried montelukast as well as another study they have tried loratadine and found there was benefit. So in adults there's hardly any study. So all that we know in adults is that there's increased urinary eosinophilia. We have to now see whether we should identify it as a target for managing these patients, and that also tells us why many of them have food sensitivities, because the epithelium is kind of open and there is eosinophil sitting there waiting to degranulate. So many patients tell you that there is some inflammation, some dietary triggers, and I couldn't show those slides on gluten. So gluten has been shown to have a significant role in non-celiac gluten sensitivity and in functional dyspepsia. So there's a very good randomized control trial which has shown that if you withdraw gluten, a large percent of these patients improve.
Yes, we'll have some questions from the other panelists also. Dr. Piyush Mishra, do you think we'll start with, in fact, Dr. Nirmal Yadav, that how often do you find an overlap between GERD and functional dyspepsia?
Frankly speaking, for us, what happens over here, but whenever we get in a general practice, we get all the time patients with both the type of symptoms. And when we do a endoscopy, 99% we find there is some GERD, and along with that, there is inflammation also, not only in the pylorus as well as in the duodenum. So this, for us, we get a combined sort of a thing. And another important thing over here is that when we see these patients, half of them already have taken so many treatment, like they have taken for H. pylori, they have taken for infection, and all the PPI, everything they have already taken. And for us, it's very difficult, especially when the PPI and everything is available on the counter without a prescription also. Right. So we have to take all the time, in spite of knowing that this is what we are dealing with, we have to send them. Recently, I sent a patient to Dr. Anil Arora for the same, to satisfy them also. Because these days in COVID time, stress is very important.
True. Yeah.
That's what I think.
The next important question would be for anyone, that do you need to have ever gastric emptying studies? So in patients with functional dyspepsia, Dr. Rajesh Senani has a lot of expertise in motility disorders. So this is a question for him.
Yes, sir. As Dr. Datta said, that if a patient has especially nausea and vomiting as their predominant symptom, then we must think whether there is associated gastroparesis. I also find that patients with gastroparesis may present with abdominal pain and weight loss. Endoscopy will show, residual food material, as Dr. Datta showed in her slide of gastroparesis. So these are the patients where we must think. If the patient is a diabetic, and especially if they're having uncontrolled diabetes with a high glycosylated hemoglobin, and they are not getting better with simple treatment for functional dyspepsia, I would like to rule out gastroparesis in this subgroup.
But will you do a gastric emptying study?
Yes, yes, we would do, sir. We would routinely do. We would do the scintigraphy. We use the sulfur colloid. And
yes, of course.
For solids and for liquids. And if there is, we have a half-life studies from our institute. If it's more than 110 minutes, the T half, then we say it's prolonged. Or if there is more than 10% residue at 4 hours. What happens is many centers don't do up to 4 hours, and that is why they miss the patient. So you have to do a complete study till 4 hours and look at the amount of residue present.
Right. Thank you, Dr. Rajesh. Dr. MP Sharma is with us. He has a vast experience and interest in H. pylori. And H. pylori, Dr. Usha did cover. So what would be your approach to a patient with functional dyspepsia? Do H. pylori testing in all, and in whom would you like to eradicate H. pylori?
According to the Rome criteria, now it has been suggested that all patients of dyspepsia should have H. pylori. And for that, you have to take up the non-invasive test like stool test or urea breath test. It has also been found that patient in our own experience, we had collected about more than 500 patients who presented at that time with non-ulcer dyspepsia. We did endoscopy on them and then found that 40% of them, 50% of them were positive for H. pylori. 10% had peptic ulcer disease, and almost 40% were functional bowel disease. At that time, we were labeling them as non-ulcer disease. Now it is advisable that if possible, in patient, if symptomatic, all patients with dyspepsia should have H. pylori exclusion. And the simplest tests are, you must do the stool test or urea breath test. Stool antigen is found to be quite effective. If we are not able to, if we are doing endoscopy, then during endoscopy you must do for H. pylori also the RUT test. This will give us an idea. The incidence of H. pylori in Indian subcontinent. A recent study has just come from Bhopal, All India Institute of Medical Sciences, where they have found 90% patients of dyspepsia had H. pylori. So one can imagine that there's so much of H. pylori going around. We have to be careful. Now, problem comes up, if how will you investigate? So the best thing will be, as Rome criteria has suggested, that any patient, before you label them as dyspepsia, please get H. pylori excluded. And the second important thing is that if the H. pylori is positive, what should we do? I think the ideal will be that we should treat them. If symptomatic, the patient should be treated. And as Usha has suggested, that there is a dysbiosis. So the antibiotic given with the H. pylori treatment will help dysbiosis also, and the patient will be symptomatic. Symptoms will improve. However, from the Western countries, the studies have shown that even after eradication of H. pylori, only 10% of those people shows improvement. But in my own experience, 30 to 40% patient of H. pylori after giving the treatment did show improvement.
Right. Thank you, Dr. M.P. Sharma. If we have some more time, we'll come back to Dr. Usha for her comments. But for the moment, we'll an aspect which has not been deliberated by Dr. Usha is the dietary advice, milk and FODMAP. So, Dr. Sanjeev Sachdeva, would you like to comment upon these aspects, that exclusion diet, or what dietary advice would you give to functional dyspepsia?
Yeah, there are a few points. First is FODMAP diet. Low FODMAP diet has been shown to be quite efficacious for IBS. And IBS and dyspepsia in real life scenario have got overlap of about 25 to 30%. So if a dyspeptic patient comes with an overlap IBS, then certainly I will use FODMAP diet as my frontline therapy. Important study is from Professor Wenner, which shows that there is a difference in the response to FODMAP diet if it is administered by a gastroenterologist versus a general physician versus dietitian. If it is administered by a trained dietitian, the response to FODMAP restricted diet in functional bowel disorders is to the tune of 90%. And if it is only by physician or gastroenterologist, it is as poor as 40%. So if you are going for a FODMAP restricted or low FODMAP diet, better involve a dietitian in your team. Second is the issue regarding the lactose intolerance. There are studies from PGI Chandigarh, your group, Dr.
You're not audible, Dr. Sanjeev.
Sanjeev,
Yeah.
we cannot hear you.
Now you can hear, sir?
Yes.
Now it's all right.
Regarding the FODMAP restricted or low FODMAP diet, the message is it should be used as a frontline treatment for people with IBS or IBS overlaps with dyspepsia. There are multiple meta-analysis and a lot of randomized control trial to support this data. Second is the issue regarding lactose intolerance or lactose restriction. There is data from Dr. Ghoshal and Dr. S.V. Rana and Dr. Kochar and Dr. Usha from PGI Chandigarh that about 80% of the patients with IBS have got lactose intolerance. So, and there is a poor correlation between self-reported milk intolerance and the intolerance we demonstrate on a breath test. So if a patient has got self-described intolerance, better is to test it through a either a lactose tolerance test or a bread test, and then you start the patient on a lactose restricted diet. Anyway, FODMAPs also have got lactose restriction and wheat restriction. So anyway, your amount of wheat and lactose is restricted if you are taking a low FODMAP diet. Last is the issue regarding the restriction of the meat or wheat or stoppage of the wheat. There has been data in IBS, a very recent study from Hamilton shows that in case patients who have got positive serology, anti-gliadin antibodies, they are the patients who respond more favorably, the IBS patient with a positive serology, than patients who do not have positive serology. And the diarrhea as a subtype of IBS is the one which responds more favorably to wheat reduction. As far as dyspepsia alone is concerned, the restriction of wheat, yes, there is emerging data from Dr. Nicholas Staley group. You can restrict wheat in a subgroup, but you need to show that there is a pathophysiological correlation. Regarding FODMAP restriction in dyspepsia, there is a role only when there is an overlap. And last is milk intolerance. There is not much data regarding the role of milk reduction in patients with dyspepsia.
Thank you, Dr. Sanjeev. So we are coming to the end of this session. Just a last question to Dr. Piyush Mishra. Do you need to prescribe anti-anxiety and antidepressants in functional dyspepsia? Dr.
Sir,
Piyush?
as per the ACG and the Asian consensus recommendations, the options we have are basically tricyclic antidepressants and SSRI. The others being the SNRIs and some newer anti-anxiety like buspirone, etc. So coming to the tricyclic antidepressants, sir, the number needed to treat in IBS patients is about 4 to obtain one positive result, while in functional dyspepsia patients, it is about 3.5 with tricyclic antidepressants. The basic advantage of tricyclic antidepressant is that they have diarrhea as their side effect. So that results in basically helpful use in the constipation predominant IBS. Apart from that, we have to remember that tricyclic antidepressants, about 1/4 of our patients have very high incidences of side effects. So we start with very low doses of tricyclic antidepressants. Now coming to the SSRIs, the basic advantage of SSRIs over tricyclic antidepressants is that they have very low side effect profile. That is the basic advantage. They are highly recommended in control of chronic pain entities. They are also effective in associated high anxiety states associated with panic disorders. The basic advantage being that they have a side effect of increased small intestinal motility. Hence, they are also helpful in the constipation predominant IBS entity. The basic limitation of SSRI, which we have to remember, is that they should not be used in functional dyspepsia patients, as one of their side effects is the induction of dyspepsias. The numbers needed to treat in IBS patients with SSRIs is 3.5. The other common drugs which some studies have mentioned is buspirone, which is basically a 5-HT1A agent, and it is an anti-anxiety agent. It is found recently to be very effective in functional dyspepsia patients. Now there is also a recommendation to use combination of two drugs in low doses, like usage of tricyclic antidepressants with buspirone for pain predominant entities, etc. I think that should be fine.
Yes,
Thank you.
Thank you, Dr. Piyush. So we had a whole spectrum of panelists talking about different aspects, and they complemented what Dr. Usha reviewed for us and summarized so well, the pathogenesis and the newer concepts. So the treatment itself is such a huge topic that we could cover only bits and pieces of that. So I'm looking at my watch, and we have exceeded the time for this particular session. And I must thank Dr. Usha and all the panelists for a very interesting discussion. Thank you, everybody.
Thank you.
Over to Dr. Arora.
Thank you, Dr. Rakesh and Dr. Usha for excellent presentation on recent advances in functional bowel disease. I'm also extremely grateful and thankful to all the panel members who have contributed very well to the discussion. With that, we'll come to the end of this session. For the next session, may I invite Dr. S.P. Mishra, who's the ex-head of the Department of Gastroenterology at Allahabad Medical College, to please take over the proceeding. The next presentation is going to be Dr. Vineet Ahuja, who does not need any introduction, at least in the Indian scenario, is the doyen of inflammatory bowel disease and is the most important international member from India in almost all the committees which regulate the management and diagnosis of IBD. Dr. S.P. Mishra, please.
Thank you, Anil. Welcome all of you. Vineet, can you unmute yourself? So now we have a wonderful presentation by Dr. Vineet, and you've already heard from Dr. Arora his credentials, and we need not introduce him because he's known to everybody, nationally, internationally. Vineet will be taking up some recent advances in the form of publications in the field of IBD. And we have a wonderful panel in Dr. Kedia, Dr. Goswami, Dr. Dilip Sharma, Dr. Neeraj Joshi, and Dr. Sudhanshu Patwari.
Dr. Mishra, Dr. Goswami may not be participating, is down with COVID. So I think you will have to continue with rest. Dr. Vineet, can you start?
Okay. Dr. Mishra, Dr. Mishra, I think you have muted yourself. Please see, I'll start with your permission.
Sure.
Thank you, Dr. Arora, for making the conference happen as usual year after year, and this year also you made it happen. So we look forward to this very interesting experience. Now today I'm supposed to talk about recent advances in IBD. And so I thought that I'll talk about 5 papers and basically use those papers as platforms so as to explore these 5 concepts. One is vedolizumab, other is ustekinumab, third is tofacitinib, fourth is treatment of ileocecal Crohn's disease, and finally, you need to talk about COVID-19 and IBD. And these are obviously papers which have come up over in the last 3-4 years, all these papers. So first is I start with the September 26, 2019 issue of NEJM, where we had 2 papers, first and second papers in NEJM, which were by the same author led by Bruce Sands. And first is vedolizumab versus adalimumab for moderate to severe ulcerative colitis, or what is also famously known as the VACITY trial. Now, vedolizumab, as for people who are not in the field of IBD, it's a kind of lymphocyte trafficking inhibitor. And when we say lymphocyte trafficking inhibitor, then in that case, we mean to say that lymphocytes, they go through the blood vessels, and subsequently they have to reach the site of inflammation, which is the lamina propria. To reach to the site of inflammation, they have to attach to certain receptors on the endothelial walls, and it is by attachment that they are able to cross the endothelium and reach the tissue. So that is how we have receptors which are on an endothelium, which are VCAM, which are MADCAM or E-cadherin, and then we have receptors on the lymphocytes, and these lymphocyte receptors attack to the endothelium, and that is how the migration occurs. Now, if we have an antibody which blocks these receptors on the lymphocytes or blocks these receptors...
Vineet, can you come closer to your computer?
Okay. When you blocks the receptors on the lymphocyte or blocks the receptors on the endothelium, those are known as lymphocyte trafficking inhibitors. And we had the first generation, that is natalizumab, and now we have vedolizumab, which has also come up in India. It is available in India now, and atrolizumab is the one which is undergoing phase 3 trials. So this VACITY trial compared the efficacy and safety of vedolizumab and adalimumab. And I'm not going to go into nitty-gritties of all these papers. As I told you, I'm going to use these papers as a platform to delve into practical issues related to these concepts. Now, if you look at this trial, we find that fairly large number of patients, multi-center international trial, around 300 centers with 700 patients. The point to be noted is that all these patients had moderate to severe ulcerative colitis with a Mayo score of around mean Mayo score of 8.7, and 20% of them had been treated earlier with a TNF inhibitor. The outcome measures were clinical remission, endoscopic response, and corticosteroid-free remission. If you look at clinical remission, you find red, which is the bar which represents vedolizumab. The clinical remission was significantly higher in patients, overall patients, and in patients who had who had not received TNF inhibitor therapy earlier, and also in patients who had received TNF inhibitor therapy. Here, the difference was not so significant. And if you look at the response rates, clearly the response rates were much better in patients who had not received TNF inhibitor therapy, and it was much lower in patients who had received previous TNF inhibitor therapy, but that is expected. Same thing was replicated for the outcome measure of endoscopic improvement, where again, vedolizumab was found to be superior in patients who had not received previously TNF inhibitor therapy, and overall also it was superior as compared to adalimumab. But surprisingly, when we talk about corticosteroid-free clinical remission, the blue bar, which represents adalimumab, it was seen that adalimumab, the corticosteroid-free clinical remission rates were much higher as compared to vedolizumab. However, this trial, the primary objective was clinical remission. That was met. So the conclusion of the trial was, on a head-to-head basis, vedolizumab was superior to adalimumab in patients with mild to moderate ulcerative colitis. Now, this is very important because it's the first trial which looked at head-to-head comparison. Now, to understand vedolizumab, I think there's another point which we should remember is that when we talk about half-lives, infliximab, let's say the half-life is 7 to 9 days. Adalimumab, the half-life is, let's say, around 10 to 15 days. Vedolizumab has a long half-life, 25 days. So if it has a long half-life, it is going to have a slow onset of action. But at the same time, the plus point would be that it would maintain the action very well. But again, a negative point would be longer weaning off would be required if surgery is planned. And overall, one has to remember it has gut homing, so it is very selective. It is not like PAN, it is not like steroid, which will immediately decrease inflammation everywhere, or TNF inhibitor, which would decrease inflammation anywhere. It is gut homing. So keeping these principles in mind, let's talk about situations and efficacies of vedolizumab in ulcerative colitis. Because the moment a drug comes into the market, so it is generally felt that, okay, it's a drug which has shown very good results. So for ulcerative colitis and Crohn's disease, so every patient of ulcerative colitis and Crohn's disease can be treated by it. Here we have to read between the lines. So this table shows that when we come to ulcerative colitis, for steroid-dependent induction, steroid-dependent maintenance, yes, it's an excellent drug. But for acute severe ulcerative colitis, no, because obviously it has a longer half-life, so you cannot use this drug. And in fact, there are studies come up which have shown cyclosporine initially you can give and then give vedolizumab, but that is okay. That's what we are discussing today. The ease of administration, it's an intravenous which is available in India. The most important thing is that chances of infection, especially TB, are least. However, for extraintestinal manifestations, this drug has not shown any much efficacy. It has not been shown to be effective if the patient has concomitant primary sclerosing cholangitis, if the patient has concomitant ankylosing spondylitis, if the patient has concomitant uveitis. Pregnancy also we have minimal data. Now coming to situations in Crohn's disease. B1 inflammatory, luminal disease, luminal Crohn's disease, it is effective. But for B1, again, luminal, which is severe disease where immediate action is required, as I told you, it has a long half-life, so not effective, in the sense that it may take its time to become effective. For structuring Crohn's disease, fistulizing Crohn's disease, perianal fistulae Crohn's disease, we do not have extensive data available. In fact, data is emerging. Right now, we have minimal data. Most of the data for Crohn's we have is for B1 inflammatory disease. Extraintestinal manifestations, again, as I told you, it is not very effective. Post-op recurrence, we have minimal data. Pregnancy, we have just, as I told you, exploratory data. But yes, infections and TB, the chance of reactivation are least, infections are least. So when we talk about Crohn's disease, actually it is B1 inflammatory where it will act. Rest of the places, either it will not, the data is not so clear. So if I consolidate both the slides for situations and efficacy of vedolizumab, then you have to remember one thing, that in ulcerative colitis, steroid-dependent induction and maintenance, yes. In Crohn's disease, B1 inflammatory, yes. Rest all situations, extraintestinal manifestations, pregnancies, fistulizing disease, be careful if you plan to use it as a first-line therapy. So if you look at the various systematic review and network analysis which are available, we find that in biologic naive patients, actually infliximab is still ranked as the highest for induction of endoscopic as well as clinical treatment in ulcerative colitis. However, if patient has failed infliximab, then ustekinumab and tofasitamab, they have been found to be superior to rest of the drugs. When we come to lowest risk of infection, then vedolizumab is the best drug. So if you were to answer this question that, okay, if you were going to use an ulcerative colitis and you want to use it as first-line therapy, which are the situations you can use it, then the answer probably would be elderly or frail patient where the risk of infection is much more, or there is pre-intolerance or contraindication to TNF blockers or previous history of solid organ malignancy. Those are the situations where may use it as a first-line therapy. Otherwise, I've told you situations where you should not be using it. Coming to ustekinumab, again, the same issue of NEJM, trial led by Wilson. Again, it was used for induction and maintenance therapy of ulcerative colitis. Ustekinumab is basically, it blocks two cytokines, IL-12, which is the cytokine for Th1 subset, and IL-23, which is a cytokine for Th17, and both of them are responsible for causing Crohn's disease. They have a common subunit P40, and ustekinumab is an antibody for that. These graphs just tell you that in this trial, ustekinumab, when it was used for patients with moderate to severe ulcerative colitis, as an induction therapy, as well as a maintenance therapy, it was found to be superior to placebo, right? And 3 years back, we had another trial which talked about ustekinumab in Crohn's disease, and which showed that ustekinumab was effective even in Crohn's disease. So we have this drug, which is effective both in ulcerative colitis as well as Crohn's disease. The question is, where are you going to place it? Obviously, we do not have a drug which gives a very good response when patients who are put on anti-TNF therapy and there is loss of response to anti-TNF therapy. What kind of drug would you use that? And this recent paper, which is actually a propensity match analysis, this is not a prospective study, compared patients who were on vedolizumab, patients who were on ustekinumab, these are patients of Crohn's disease who had prior failure to anti-TNF therapy, and you find that by 52 weeks, patients who had corticosteroid-free remission, biochemical response, both ways, ustekinumab was superior to vedolizumab. So in other words, that satisfies a big deficiency which people had been facing, and ustekinumab is another drug which probably in a year or so may come to India, so it's important to know about it. That what is the second line therapy for patients with moderate to severe Crohn's disease? So a first line therapy is infliximab or adalimumab. Ustekinumab is a preferred second line agent. Another point out here is for both the biologics, vedolizumab and ustekinumab, a meta-analysis which came up recently showed that as azathioprine or methotrexate may be required concomitantly with infliximab. For vedolizumab and ustekinumab, for both of them, in ulcerative colitis as well as Crohn's disease, you do not require a combination therapy. Combination of therapy is not required when you're using both these agents. Now we come to the third drug, tofasitamab. This trial came up in NEJM 2017, induction and maintenance therapy for ulcerative colitis. Now the tofasitamab belongs to a special class of drugs known as oral small molecules, which can be taken orally. They have a small molecular size. The mechanism of action is they block Janus kinase proteins, JAK1, JAK2, and tyrosine, JAK3 and tyrosine kinase. So initially we had filgotinib. Now these are hydrocarbons. So as a result, they do not have any immunogenic responses. So they do not have any immunogenicity. So earlier we had filgotinib, and now we had tofasitamab, and now filgotinib also has come up, which is a JAK1 inhibitor. So Octave trial, that is NEJM trial 2017, showed that when 10 milligram twice a day induction dosing for 8 weeks was given for tofasitamab, followed by 5 milligram twice a day maintenance dose for tofasitamab for 1 year, it was seen that tofasitamab was superior to placebo, clearly establishing that tofasitamab also has a role to play in management of ulcerative colitis. The same kind of response, however, was not seen in patients with Crohn's disease. Now, another thing to remember out here for tofasitamab is its half-life, 3 hours only. Compare it with vedolizumab, half-life of 25 days. Infliximab, 7 days. So in other words, the action for tofasitamab starts within 3 days. So if you have to stop it and the patient has to go for surgery, post-operative complications probably would be less. Very interesting thing, if its action is fast, case series have come up whereby in acute severe ulcerative colitis, if a patient has failed IV steroids, given infliximab, failed infliximab, then high dosing of tofasitamab has been used for 3 days so as to prevent colectomy. That is a very upcoming area. So this slide shows that what is the placement of tofacitinib? Again, it is not a first-line therapy as yet for ulcerative colitis. Definitely, it's a second-line therapy when there is no response to TNF inhibitors. Both ustekinumab and tofacitinib have shown that in this particular subset of patients who have failed TNF therapies, these are the two therapies which work the best. In Crohn's disease, tofacitinib has not been found to be useful. Tofacitinib is available in India in terms of the dermatology people and all. So some people have started using it, but remember when you're using it, cannot be given in pregnancy. Strictly no, it causes hyperlipidemias, it causes cytopenias. You need to monitor the liver function test. You need to monitor the kidney function test. Another, but more, very importantly, it can give rise to herpes zoster in elderly. So preferably herpes zoster vaccination should be given. And it can also give rise to thromboembolic events. So anybody who's predisposed to thromboembolic events, you would not like to give it. So the advantages of using tofacitinib is it is also useful in extraintestinal manifestations. We talked about vedolizumab, which cannot be used in extraintestinal manifestations. It's an oral drug, short half-life, no immunogenicity. Disadvantages: increased risk of thromboembolism, cannot be given in pregnancy, elderly one would be careful. So this is how the treatment algorithm for ulcerative colitis is evolving. So if a patient is, let's say, on mesalazine, he is not responding, then you would give steroids. Steroids, budesonide MMX has not come up in India. This is not the budesonide which is available right now in India. This is a budesonide MMX which gets released only in the colon. So budesonide MMX can be given or steroids can be given if the patient becomes steroid dependent. Earlier we had choices like azathioprine, infliximab, but now we have choices like vedolizumab, tofacitinib, and ustekinumab in all these group of patients. Not only that, in some of the very refractory patients, people have been using dual biological therapy in terms of combining two therapies. Now let's come to the surgeons. Very important trial with the results of which were awaited because this trial took 7 to 8 years to happen. This trial first results came up in 2017. This is known as famously as a LYRICS trial from the Dutch group, showed laparoscopic ileocecal resection versus biologics for patients with terminal ileitis, patients of Crohn's disease who only have terminal ileal disease, but less than 40 centimeter of terminal ileal involved, non-structuring disease, failure to respond to steroids and thiaprines. What would you do? You would say, let's put the patient on biologics. So the issue out here was, can surgery, can laparoscopic ileal resection provide with good long-term, short-term, and long-term results? Over 7 years, 143 patients only could be recruited, and the primary objective out here was whether the quality of life, IBDQ score, and an SF36 score, which again looks at the quality of life in a way, at 1 year, what was the difference? It was seen that whether patients were put on biologics or the patient went for surgery, the results were same. In terms of side effects, the side effects were also similar between infliximab group and the surgery group. Came up the next part of the study, which I believe is much more interesting, although it is a retrospective analysis. This came up this year only in June. And this talked about all those patients who who either received infliximab or underwent ileocecal resection when followed up for a period of 5 years. What happened to them? So there's a complicated bar chart out here which shows that there are 69 patients who are in the resection group and 65 patients in infliximab group. If I simplify this chart, then I get these statements. Patients who underwent resection, nearly half did not require any therapy, 5 years follow-up. Only 1/4 required biological therapy. None required a second surgery. Whereas patients who were in infliximab group, all patients required therapy. Half of them required continuation of biologics or escalation of biologics. Half of them required surgery. So these figures speak for themselves. So what we learned from these two studies is that early surgery should be part of the multidisciplinary approach when it comes to ileocecal Crohn's disease. Here in this case, we can say non-stricturing, although for stricturing, we don't know, it might be the same, particularly if it's a single stricture localized to ileum. So these studies these are the first RCTs, surgery versus infliximab. 1 year of follow-up, they showed similar quality of life scores, cost effectiveness was equal, but the 5-year follow-up showed that following resection, only 1/4 patients required biologics. In other words, ileocecal resection for limited segment affected less than 40 centimeter compares very favorably to anti-TNF therapy. Finally, I come to the last thing, that is COVID-19 and IBD. Now, that is, I think, the fastest moving area where, because what I feel the opinions have radically changed. The first paper which you can see on the top panel came up It has been published in July, but it was made somewhere in April and April only. And if you look at the recommendations of this paper and subsequently this paper which came up, which looked at acute severe ulcerative colitis, which came up recently, then you find the difference. The recommendations of the first paper, just some of the recommendations I'm touching out here is, if you look at all the therapies, it was felt at that time that prednisolone, and we look at therapies which may increase the risk of COVID, which should be stopped or dose reduced to prevent infection, should stop if the patients develop COVID-19. It was felt that yes, except for 5 ASs, all therapies probably should be stopped and maybe vedolizumab may be continued. But definitely, if the patients, what may increase the risk of COVID, even if when patients have not developed COVID, was prednisolone. It was felt that steroids should not be given to patients in IBD patient group, even when they do not have COVID, and if given, the dose should be 20 milligrams. And vedolizumab was thought to be safe. The whole scenario changed a little bit because if you look at the recommendations now for acute severe ulcerative colitis, it has been seen, yes, if a patient of acute severe ulcerative colitis is admitted with and he has COVID-19. So this is often a bone of contention between different people. Okay, how are you going to treat it? What are you going to do it? Then it seems to be quite clear right now, I would say, on the basis of a combination of experience over past 2-3 months of various groups, that yes, IV steroids can be given. You can give, in fact, full dose IV steroids. If the patient does not respond to IV steroids, sigmoidoscopy can be done before going to second line therapy. Thromboprophylaxis can be given. Patient is not responding to IV steroids, you can go on and give infliximab. In fact, case reports are available where COVID pneumonia resolved when infliximab was started. Not only the colitis resolved, the COVID pneumonia also resolved. There was a lot of hesitation for sending these patients for surgery because it was felt the results of surgery would be bad. But if a patient has acute severe ulcerative colitis not responding to medical therapy, colectomy should not be delayed. Steroid taper may be a little fast. Azathioprine, yes, you may still have some reservations and may be started once the patient is COVID-19. So overall, if I give a summary, then I would say vedolizumab is a welcome addition, but remember, it's a good drug, it's a safe drug. But at the same time, don't be over enthusiastic. Be clear that it is not for all cases of IBD. There are situations where it is useful, but situations where efficacy data is still lacking, it has, yes, the least risk of infection. Ustekinumab, it fills up an important gap which was there in terms that it is the best second-line therapy when anti-TNF fails for both UC and CD. It may become the first-line therapy subsequently as more data emerges, but right now it is the best second-line therapy. Tofacitinib has a fast onset of action, convenient to give, oral small molecule. It competes with ustekinumab in being a second-line therapy in ulcerative colitis. Ileocecal Crohn's disease, go for early surgery. It seems to have very good results, particularly when the disease is limited to terminal ileum less than 40 centimeters. And if you go strictly according to the trial, there should not be any stricture. COVID-19 acute severe colitis, you can practically treat the same way as you used to treat before. Thank you very much for your attention, please.
Thank you, Vineet. Wonderful presentations. And it was so lucid, and you took over you told us the pros and cons. Yellow. Hello, can you hear me?
Yes, sir, we can hear you.
Something wrong?
No, we can hear you. We can clearly hear you, sir. So maybe I'll start the discussion. Professor Mishra was supposed to start the discussion.
Vineet, you can continue the discussion.
Okay, so first, Saurabh, first question for you, Dr. Saurabh Kedia. So what are your comments on vedolizumab? Like, what do you think about vedolizumab? What is your perspective on vedolizumab?
Good evening, sir. And first of all, my thanks to Dr. Arora for this opportunity. So, sir, as you discussed in your presentation, that vedolizumab would be a good option for patients with steroid-dependent UC, both for induction as well as maintenance of remission, especially when if the patient has a moderate disease, and especially the concern if the patient is elderly, frail, or there is a high risk of infection, because in that case, vedolizumab scores over other biologic agents in the term that is the least risk of infection, especially tuberculosis in the Indian setting. it would be a good option in this scenario. But for other indications such as acute severe colitis, vedolizumab is not a good option. It will not be given, but it has a very slow onset of action, and it's good over vedolizumab for patients with acute severe colitis. If we go on to Crohn's disease, then for patients with luminal Crohn's disease, with moderate to severe disease, vedolizumab can be an option in comparison to other biologic agents, especially if these patients, as I discussed, are like risk of infection elderly or frail patient. For patients with crystallizing Crohn's disease, the data is limited. Only 2 or 3 studies which have shown that 1/3 of patients only show response. So still, we are not clear about the role of vedolizumab in crystallizing Crohn's disease. And again, in patients receiving Crohn's disease, we don't have enough data to recommend vedolizumab as a first-line therapy. It can be tried in patients with failed anti-TNF agents. Yes, then it is an option for treatment, but for TNF-naive patients, vedolizumab is not a good option in this group of patients.
Saurabh, can I ask you a question? If you have a crystal ball gazing, do you think vedolizumab will ever take off? Because 2 other better drugs are there.
Your voice is breaking. Sir, your voice is breaking.
Do you think vedolizumab will take off? Because ustekinumab and imitinib, there are 2 drugs which are wonderful drugs. One of them is an oral agent.
I think there is something wrong with his audio. Can you, Dr. Mishra, pass it on to some other panel member? Same question. Maybe Vineet can answer that.
Okay, Vineet, there are 2 drugs. One of them is an oral drug. You already said.
I'll tell you where it will definitely have a place. The place is that we are gradually moving towards dual biological therapy, particularly for refractory cases, like so that you have a combination of ustekinumab plus vedolizumab, infliximab plus vedolizumab, right? You're gradually moving towards that direction. So that way, vedolizumab would definitely have a role.
Why not use an oral agent rather than an IV agent? Except for
tofacitinib, it is very difficult to combine with other agents. It would be toxicity would be too much for tofacitinib to combine. Vedolizumab is a safe agent. So for certain situations, it would remain a good drug. The only thing is that vedolizumab, we have etrolizumab coming up, which is another generation ahead of it. That would block the alpha E beta 7. So once because it is like hepatitis C virus. There is so much of work going on, but by the time a drug comes up, stays for 3-4 years, by the time there's another drug which is already there to replace it. So etrolizumab would replace vedolizumab, and etrolizumab, if it replaces vedolizumab, still it would have a role because dual biological therapies may come. But right now, for the next 2-3 years, it has a lot of scope.
And what about elderly? In elderly, you'll use vedolizumab?
That is the only place where you may use it as first line. History of infection where you are scared, you may use at first line therapy. Otherwise, infliximab still remains the first line.
With a large background population of tuberculosis, do you think it will be useful in India?
I think it should be useful, but once it gets used out here, then we'll get to know whether what happens between tuberculosis and vedolizumab. That is something we can answer after 6 months.
Okay, Dr. Goswami is not there for taking up questions for ustekinumab. You already said that it's a good second-line drug whenever infliximab fails, even in ulcerative colitis and Crohn's disease, so we can use it. Again, what's your perspective on this drug?
I think ustekinumab is going to be a star molecule, I feel, because the kind of response it has shown, it seems to be good, but again, it has its limitations. For example, we had one patient who was initially on infliximab, then he shifted to Canada, young boy, then he was on this thing, vedolizumab, then he went on to ustekinumab. For 2 years, 3 years he was very fine. Just 2 weeks back he underwent surgery out there. So for 2-3 years, if it's an aggressive disease, 2-3 years, you switch over from one drug to next drug, that's how it keeps on.
One swallow does not make a summer.
Yeah, you can say that.
Okay, we move on to tofacitinib. Dr. Sharma, can you unmute yourself, please? Can you unmute yourself? You're muted. Okay, now you unmute. Your perspective on this drug, oral drug? I think this is a wonderful drug, except for the side effects, which are too many.
Yes, sir. Dr. Vineet has already clearly suggested us that it's a wonderful dog, but still a second line one. I just want to add on something like, Dr. Vineet, kindly elaborate which sort of patient we are going to use this drug, especially in the setting of current trials and all the literatures.
No, you have to answer that.
Like,
never mind, Vineet, come in, please.
No, so
Vineet,
Dr.
come in, please.
Dilip, like in the sense that you have started a patient on steroids, doesn't respond, you move over to biologics, patient does not, patient of ulcerative colitis does not want to undergo surgery, you try tacrolimus, he doesn't want to go for surgery, you move to biologics also he does not respond at all. Then you need another agent. So there again, you push the patient for surgery. The patient does not want to go for surgery, because he feels, okay, there's another agent available, he can afford it, why not try it for 3 to 6 months? There, the second line drugs come up. So tofacitinib can be given there, ustekinumab can be given there, vedolizumab can be given out there. So amongst all these agents, it seems that ustekinumab and tofacitinib, they provide the best responses in patients who had failed previous infliximab or adalimumab therapy.
Thank you, Vineet, for clarifying it. But the side effects are too many, I believe.
Side effects of infliximab are also too many. Side effects of steroids are too many. Any immunosuppressive therapy, you're going to have side effects.
Okay. Now we move to the surgeon. Dr. Joshi, can you unmute yourself, please? Good.
Hello, sir.
So what's your opinion about ileocecal resection? 40 centimeters, 50 centimeters?
First of all, I'm not a surgeon, I'm a physician.
Neeraj is from Nepal. He's a top gastroenterologist from Nepal.
I'm talking about we're moving to surgical aspect. So your opinion from the gastroenterologist perspective.
So in terms of limited ileal disease, if the patient has got obstructive symptoms and there is not much inflammation, surgery is the preferred treatment, and that is more or less widely accepted. The debate is on what would you do in patients who have non-stricturing disease, but the disease is predominantly inflammatory and limited to ileocecal area. And as Professor Ahuja showed in the LYRIC trial, that if you give them upfront surgery as the primary treatment, they do really well, even 5 years down the line. None of these patients needed repeat surgery, those who had upfront surgery in the beginning. And that's what I have been doing as well in my practice. If patients have disease which doesn't respond to conventional treatment with steroids and immunomodulators, because the biologics are very expensive and most of my patients cannot afford, I have been sending these patients to surgery, and the LYRIC trial just re-endorses what my practice has been. And I think this is very relevant.
You're sending them for open surgery or laparoscopic surgery?
Now I have a surgeon who can do laparoscopic surgery. In the past, I had been sending them for open surgery, but now I have a surgeon. For the past few years, I've had a surgeon who does colorectal surgery and can do laparoscopic resection of these.
So go back to Vineet. Vineet, any comparison between open surgery and laparoscopic surgery?
No, it's not. There's no comparison available, but obviously laparoscopic is something which one would
logically
if not available. Open surgery should be fine.
Thank you, Dr. Joshi. And I don't see Dr. Patwari there. Is it there? Never mind. COVID is rapidly developing and things are changing, as you said, Vineet. Steroids were not used. It's useful in, even infliximab is useful in COVID. So probably we are still, Dr. Patwari is there. Good evening, sir.
Yeah.
Can you hear me?
Good evening, sir. Good evening.
So you heard about COVID. What's your perspective? It's such a changing, rapidly changing scenario is there. The jury is still out. What's your opinion about COVID and IBD?
Yeah, actually, initially we thought the COVID, the colitis patients may be highly exposed to COVID-19. But if the patient is they're not at higher risk of the COVID patient.
So his audio is not good. Vineet, any...
there is a severe colitis.
I think it was...
it was
Yeah, Dr. Sudhanshu, there is something wrong with your audio.
Vineet, any
Maybe can you just
prognostic
back
markers
it up?
from the point of view of COVID, ageusia, anosmia, or whatever it is?
No. Diarrhea. Initially, people thought that people who have diarrhea, they are bound to have a prolonged course and all those kind of things. But subsequently, I don't think it was proven. One. Number two, initially it was thought that people with IBD would be more prone to COVID. Again, it was proven wrong. In fact, it was seen that patients who had IBD, they are the soluble ACE2 receptors. They were subsequently the interaction of the soluble ACE2 receptors were more, and as a result, because of that, the interaction of the virus was more with the soluble ACE2 receptors. As a result, inflammation was less. So IBD patients are not more prone to this thing. It was thought patients with biological therapy would be prone. No. Then came up the dexamethasone trial from UK, which clearly showed that you can give steroids. So overall, when it comes to, as in chronic liver disease, cirrhosis is one subset which is prone to complications of COVID. The mortality rates are higher in acute and chronic liver failure. That phenomena has not been seen in IBD. That is
Vineet, my question is, are there any prognostic markers from the point of IBD or from COVID point of view which predict a bad outcome in IBD patients?
That is if the patient has active disease when he develops COVID.
And from COVID point of view,
number two, what has been seen from secure IBD registries, if a patient was on 5-ASA, those patients after did the worst as compared to patients who were on steroids.
Can I just ask a question, sir?
Sure.
Professor Ahuja, some of the trials you showed, you have these new molecules compared against placebo. And in patients who have moderate to severe ulcerative colitis, you're giving placebo in one arm. Is that ethical? I don't know how they get through this.
The standard of care is continued. It's placebo doesn't mean that they're not on any treatment. It is standard of care is continued. Standard of care plus placebo, standard of care plus, let's say, tofacitinib.
But the standard of care has failed in these patients. And that's why they were recruited, weren't they?
So that is why there's an induction period of 8 weeks. If the patient overall 6 to 8 weeks, because if you look at the placebo response is also generally in these trials 20 to 30%. Number two, the initial induction phase is only for maximum of 8 weeks. It is not for 44 weeks that they keep on continuing if the patients are not doing well. And then also they build in another rider in between is that after 4 weeks, if the patient drops by these many points in the scores, then the patient has to be taken off and put in the open. So these are things which is built in. But again, as I clearly agree with you, it would take a lot of courage to do a head-to-head trial. Because again, in VACITY trial, it's a clear-cut case of smartness. You know that infliximab is better than adalimumab in patients with ulcerative colitis. Marginally better, but better, right?
Yes.
So they could have done a head-to-head trial of vedolizumab with infliximab. Now, in this trial, they did a double-blind placebo-controlled trial where they gave adalimumab and also gave placebo injections, IV injections, because adalimumab is given subcutaneously. Vedolizumab is given intravenously, right? So they could have easily compared infliximab with vedolizumab. They would not have had to give any placebo injections at all also, and they would have had a good comparison, but then the chances of trial being successful would not have been there. So
Okay,
this
thank you very much. We are finished our allotted time and we have recovered some time. Thank you, Vineet, for getting it fast. I thank Vineet Ahuja and all my panelists and Dr. Anil Arora again for having a wonderful conference. We'll continue with the conference. Thank you very much. Thank you very much, all of you.
Thank you. Thank you so
Thank
much.
you, sir. Thank you.
Thank you, Dr. Mishra, for excellent moderation of the session. And I'm also extremely grateful to Dr. Vineet for sticking to the basics of what we wanted. We did select 5 important articles which are going to change the management of IBD in near future. Thank you, Vineet. And I am also thankful to all the panel members who contributed significantly to the discussion. With that, we come to the end of the second session and we switch on to the third session of the day. The topic is recent advances in celiac disease. We are lucky to have 2 doyens of celiac disease from India occupying the highest chair in the international guidelines for management of celiac disease, Dr. Govind Makharia and Dr. A.S. Puri, who are going to be presenting to us the recent advances. May I hand over the proceedings to Professor A.S. Puri, please.
Sir, unmute yourself, please.
Sir, please unmute your phone. Thank you, Dr. Anil, and once again, congratulations for organizing this
this conference, very successful conference against all odds. So I would now request, because we're a little behind time, approximately 10 minutes, so I'm just, with your permission, if we can just go straight to the talk, and after the talk is over, then I can bring in the other panelists. So for the sake of covering up the lost time, I'm going to request Govind to start his talk. And Govind, of course, does not need any introduction in any forum, and least of all in the case of celiac disease. So over to you, Govind.
Very good evening, everyone, and thank you so very much for your kind invitation, Dr. Arora. Thank you, Dr. Puri, and we will have a panelist, Dr. Mukhivar, Dr. Jayanti, Dr. Bhatia, Dr. Chaudhary, and Dr. Jayant Ghosh. So I'll make a presentation on behalf of the panelist and the moderator. So what are recent advances in celiac disease in recent times? So I'll cover a couple of headings, like talking about what's new in epidemiology, what's new in the spectrum of celiac disease, what's new in diagnosis, biomarkers, novel therapies, and how do you monitor these patients. Coming to first question, that what is the burden of celiac disease globally and in our country? And this is very important to know, because people believe that celiac disease was uncommon some time back and it's occurred only in some part of Europe. But now we know that celiac disease is a global disease. Of that, we have a modern epidemiology, and this modern epidemiology has been possible because of invention of very reliable serological test which can be done in the population to estimate prevalence of celiac disease in any community. Unlike many other disorders where making a prevalence study are quite difficult, for celiac is as easy as doing some blood test in the population. So modern epidemiology came for the first paper in 1992, and that's from Italy, and that set the ball rolling about estimating burden of celiac disease in different parts of the world. And so then in the United States, when celiac was not to be common, but this paper published in 2003 showed that 1 in 130 Americans have celiac disease. And these two papers have changed the belief about celiac all around the world. And after that, the number of studies had come from different parts of the world. And then what we did a meta-analysis of all the studies published about 2 years back. And one of our bright boy, Prasant Singh, did this meta-analysis where we looked at all the studies published, and we found that the prevalence of celiac disease, or seroprevalence of celiac disease, is about 1.3% globally. To estimate prevalence by two means: one, that looking at serology in the population, and those positive, you do biopsy, that becomes biopsy confirmed celiac disease. So most studies have done only seroprevalence. So globally, we can see that 1.3% of global population are seropositive for celiac disease, and it varies in different regions of the globe. And one of the important regions that certain countries, including Europe and India, are one of the top ones which have a high prevalence of the seroprevalence of celiac disease. And coming to the biopsy confirmed celiac disease, what is the global prevalence? And again, this is a same internal shows that about 0.7% of global population have biopsy confirmed celiac disease. And if you look at the world population of 7.4 billion people, then about 37 to 60 million people around the world have celiac disease. And it affects every continent. It is not that some continent is spared, it affects every continent of the world, be it North America, Europe, or even Africa. There is a celiac disease. People believe celiac not there in Asia, but even Asian data suggest that celiac is as common in some of the Asian countries, not all. Some of the Asian countries is as common as the rest of the world. And the celiac common in Asia are countries like, say, India, Turkey, Middle East. All these regions have celiac disease as common as the rest of the world. So they have been increasing prevalence, and if you look at the two different regions, different timelines, one in between 1991 to 2000, and next decade, we find there is a prevalence increase from 0.6 to 0.8. So also, it's not only that there are prevalent cases, but there's also increasing number of patients with celiac disease. Coming to the incidence of celiac disease, what are new patients coming with celiac around the world? And this is published this year, very nice article, which shows that global incidence of celiac disease in adults is 12.9 per 100 lakh population per year, 12.9, and is more in children. So 12.9 people, new people are added per lakh every year in the population. And if you look at this number is increasing, this incidence increasing about 7.5% every year. And in every country, if you look, we draw the incidence data, the incidence is increasing in most countries of the world. So meaning thereby, we are not only we have old patients with celiac disease, but we also new patients are added to population every year. Because celiac disease is a chronic disease, and therefore new patients will keep adding to already existing burden of celiac disease. So coming to our country, again, our country, we have first study coming from Dr. Ajit Sood, showing 1 in 300 has celiac disease, then a study from New Delhi, showing that 1% of North Indians have celiac disease, and then a pan-India study which was led by Dr. Ramakrishna, which shows that we have pan-India prevalence is 0.6%, as good as the rest of the world, and is more common in northern part of India. This is more common in northern part of India and is less common in southern part of India. Is also as common in northeast, slightly less than northern part of India, but we don't see that many patients in real life. But if you look at the blood-based data, 0.8% of northeastern population have seroprevalence of celiac disease. But we are not able to pick them up this point of time, mostly because of there's lack of awareness about this. And if you look at all the data together, our country will have at least 60 to 80 lakh people of Indian will have a celiac disease, and only few of them are diagnosed. Majority remains undiagnosed. So I just drawn to make also understand that what does incidence and prevalence means. Look at the prevalence data of, we have globally about 5 crore people have celiac disease, and look at incidence, we will have at least 10 lakh people will be added every year globally. Same in our country, we will have about 40 to 50 lakh people having celiac disease, and about 150,000 people will be added every year in India with diagnosis of celiac disease. Question comes, will South India will have celiac disease? We don't have any data, but look at some reasons for that. And we believe that even South India celiac disease will emerge with time. The two important factors which lead to celiac disease is the HLA-DQ haplotyping in the population. Is the population genetically susceptible to celiac disease, or if people eat wheat? The two most important components. The first component is HLA-DQ2 and DQ8, and it is seen that all three regions of our country have equal community prevalence of HLA-DQ2, DQ8. It means our population is predisposed to celiac disease, be they are in the northern part of India or be in the southern part of India. Only difference at this point of time is that the South Indians take less amount of wheat. That might protect them from having celiac disease. But this also does not look to be true now, because the data which came, a very nice study came published in JAMA last year, which shows that if population eats more wheat, they will have the risk of celiac disease increases. And it is said that if you eat 2 grams of wheat at 2 years of age, 2 grams of wheat is about less than a chapati. 2 years at 2 years of age, the risk is as good as the rest of the population. Therefore, we believe that wheat also increasing in many parts, wheat consumption is being increased in many parts of the southern part of India. So even there, people are exposed to wheat, and therefore celiac disease may emerge in southern part of India, and we should keep our mind open that celiac disease at present is less common, but it may not be true forever. So summary one, that celiac disease is a global disease, and in India it is as common as in Europe and North America. Certainly it is less common in southern part of India. Now, second point is that the spectrum of celiac disease is expanding. We believe that the celiac disease is a disease affects only a small intestine, but it's not true. Celiac disease is truly a multi-system disease and affects many different parts of organs, including liver, the brain, skin, and many other things. So the symptom of celiac disease may not be limited only to GI tract. They can have symptoms to many other organs. And the list is exhaustive. I think most of the gastroenterologists will know this. They can have hematological patient come just with anemia. They may not have diarrhea. You know, Dr. Puri published that half of patients have a non-diarrheal type of celiac disease. It means there's no diarrhea. So we should stop thinking that there's no celiac disease if there's no diarrhea. We will lose patients. Celiac disease patients can have no diarrhea, but can have any of these manifestations. They can present just with anemia. They can present just with short stature. They can have liver disease. They can have multiple endocrinopathies. They can have just osteomalacia or osteoporosis. Or they can have even psychotic manifestations. And some of the patients with celiac disease do have infertility. So one should know that it's like a truly multi-system disease, and this disease must not be limited to only gastroenterologists. This disease is like a common disease, and in fact, this disease should be diagnosed by primary care physician rather than by gastroenterologist. So what are the conditions which is the high risk of celiac disease? So looking at, I just said, anemia. So if you look at all 100 patients with anemia, so of 31, one will have celiac disease. So if you see identified anemia, think of celiac. One of 31 will be celiac disease. Short stature, almost 1 in 10 with short stature will have celiac disease. Celiac disease can also present with diabetes, and this is very important. And this is a meta-analysis we have completed. A very bright student, Sakira, has done this work, and whatever reports are available, they are not really great studies, but small studies. So just 1 in 7 cryptogenic cirrhosis have celiac disease, so 1 in 7. And if you treat these cryptogenic liver disease, if they have celiac disease, the liver architecture improve and liver functions improves. So therefore, we cannot miss these some of the patients with cryptogenic liver disease having celiac disease. And this is really, really important. Same that lot many cryptogenic patients will have a TTG positive. About 1 in 30 patients with functional GI disease will have a celiac disease. So those who have especially IBS-D or IBS-M should be screened for celiac disease. When you see type 1 diabetes, must look for celiac disease. About 6% of type 1 diabetes will have celiac disease. Means 1 in 16 type 1 diabetes will have biopsy confirmed celiac disease. Same, if you have a celiac disease, we need to screen every first degree relative of patient with celiac disease, because almost about 13 in 100 will have celiac disease. Likewise, those patients who have infertility, the risk of having celiac disease is almost 3-fold higher. So therefore, it's good that if you have worked for other cause of infertility in women, look for celiac. And in some, it may be rewarding. If they have celiac, people do conceive after treatment with gluten-free diet. So in summary too, that there's expanding opportunity, there's expanding spectrum, and therefore opportunity. Why say opportunity? Because celiac disease is a small intestinal mucosal disease. Mucosa improves completely. There's no scar. You can treat this patient at any point of time. There will be complete recovery. But we know, as we know, that it also affects other organs too, where the regenerative capability may not be great. Somebody has a cirrhosis, liver will not recover completely. You may retard the process, but it will not revert completely. If there is osteoporosis, it will not recover completely. If there is a short stature, it cannot recover completely. Therefore, it's important to diagnose these conditions as early as possible and treat them effectively. Therefore, we are able to treat them and avoid all this complication. Coming to third aspect, that now making a diagnosis of celiac disease is much easier. You look at evolution of celiac disease diagnosis. Before 1990s, we didn't have blood tests, and we diagnosed by 3 sequential biopsies. So difficult to make a diagnosis. Ever since we had serology coming to available for clinical practice, the diagnoses have changed. And the first Spaghan criteria came in 1990, which allowed us to diagnose celiac disease just by 1 biopsy rather than 3 biopsies. And ever then, serological test led to further modulation and further improvement, because there's a good evidence that if the TTs is high, you can predict that there is a villus atrophy. Therefore, people are thinking that if you can make a diagnosis without even biopsy, and therefore that led to a biopsy-free criteria. And again, the Spaghan 2 in 2020 and Spaghan, in 2020, first in 2012 and second in 2020, changed the criteria. And you can diagnose celiac disease in earlier criteria. If you have symptoms, TT is positive, or you demonstrate there's a biopsy showing villus atrophy. But again, they said that if you can't do biopsy, then you have to have a TTG which is very high, 10-fold high. You have to have EMA positive. EMA means anti-individual antibody, and the HLA-DQ to DQ8 also positive. It means all 4, if they are there, then you can avoid doing a biopsy. But in 2020, this criteria were further simplified, that you did not do HLA-DQ to DQ8, and you can diagnose celiac by non-biopsy pathway if even patient is symptomatic or asymptomatic, but TT is a high 10-folds and EMA is positive in second sample. You can diagnose celiac disease. But there are a lot of caveats, 2 major challenges. While the criteria is so clean and clear that TTG must be 10-folds and EMA should be positive, but what we practice differently, that people don't use this criteria as written in the guidelines. People use inappropriately these guidelines, and also we should realize that TTG has a lot of variability in its performance. And I dwell upon this for a minute. The 2 papers published last year in our own journal, the Luminal Gastroenterology. One paper came from England, another paper from Delhi, Apollo. And here in pediatricians practicing in Southwest England, they were asked that, are you aware of non-biopsy pathway of Spaghan? Of 100 say yes. Then only 17 said that all criteria are required for making a diagnosis. And 33 of them will make a diagnosis even at low titer of TTG, just for low titer TTG, and even patient is symptomatic. Means the guidelines are written, but they're not followed as good. And same is from our own country, that pediatricians, it again is a questionnaire-based paper, that only half of pediatricians follow these guidelines, and almost 1/4 will make a diagnosis based upon single TTG value. And this is a great challenge, because the performance of TTG is not great. The performance of TTG varies the kind of kit you use, and a kit may have a high sensitivity, like this kit has highly sensitive, but less specific. And some of the kits, the sensitivity is still low. And there are data now, at least in this study which we did, comparing the performance of diagnostic kit in India and a cohort in US. And what we found, that kit which works good in our country doesn't work good in US. So there's a lot of performance variation in the serological test. Therefore, serology is not extreme, is always reliable, and we must make a note of that. People always say that biopsy is invasive, can be diagnosed without serology, and therefore we require if we have a biomarker which can predict that we can make a diagnosis of celiac disease even without doing biopsy. So do we have any non-invasive biomarker which can predict presence of villus atrophy? And in fact, there are a couple of biomarkers which have been explored, including cytochrome 3A4, plasma citrulline, and fatty acid binding protein. So going to, in summary, that the citrulline is a non-amino acid, amino acid which is not utilized in protein formation, and citrulline is synthesized in small intestinal mucosa, in enterocyte. So if there's a less enterocyte because of villus atrophy, there will be less citrulline. And therefore, there are many studies available. The citrulline may be low in celiac disease, Crohn's disease, and HIV enteropathy, and many other conditions. Therefore, we also did a study and showed that in celiac disease, citrulline is really, really low. And if you have citrulline less than 30 micromole per liter, this predicts presence of villus atrophy in almost 78% with a 95% specificity. And this is a likelihood ratio for diagnosis is almost 17. That in a patient who have a TTG positive and there's a low citrulline, you can predict that there is a villus abnormality. So this is a good biomarker. Same as the other protein, which is a fatty acid binding protein, and this protein is important protein present on enterocyte and is required for carrier of long chain fatty acids, which it carries that long chain fatty acid. So if there's damage to enterocyte, the fatty acid will be released into circulation. Like in injury to hepatocytes, ALT get released into circulation. Therefore, if there is a damage to enterocyte, there will be release of fatty acid binding.
I'm sorry to interrupt you, but we're really running a little behind time. So if you can just speed up a little because we want more time to discuss your talk. Carry on.
I'll try to as soon as I can. So FABP can also be an marker, and there are many studies, even our own study shows that FABP could be a good biomarker. And if you combine both FABP and citrulline, this can predict presence of villus abnormality. So moving to one other aspect, and which is very important, I believe, that there are some patients who are put on GFT without any confirmed diagnosis. And if they improve, is fine. If they improve, they ask question, should I continue GFT? What did you? You don't have great, and if you reinvestigate, you find all tests are negative. You're not sure that we can give this treatment lifelong, prescribe lifelong to these patients, advising them to take gluten-free food. So we need to have biomarker to that. And this is a great study has come from Oslo that this is called gluten tetramer. So if these patients are challenged with gluten, this T cells which are bound to HLA are rich in blood, and you can pick up these by flow cytometry. So there's a new test coming up now. This have been patented and it's now being under the clinical validation that to challenge we can have this biomarker. There are many other biomarkers available, so I'm not going into detail of those. So summary 3, that diagnosis making is much easier, and we have a lot of biomarker on horizon. The number of things have come up in more on the basic biology or fundamental science in celiac disease. And just to tell you that now we have an animal model for celiac disease. It's great work from Chicago, Mana Jabri's group. Now we have an animal model for celiac disease, and also a great work from her published in Science about 2 years back, that a virus can trigger the precipitation of celiac disease. We always ask question that when the celiac arises, many times we diagnose celiac disease in middle age or late age. At this point of time, there's data that virus can play a role and precipitate the disease. So moving on to my next question, I will just skip a couple of slides and go to one important aspect, that is new treatment, novel treatment of celiac disease. I'd like to say a couple of words about this. And if you look at pathophysiology of celiac disease, now getting explored much better, and we know that why celiac disease occurs. There is we know gluten peptide. The wheat has a gluten protein and has many peptides. Gluten is not digested completely because the amino acids present in gluten have more of a proline and glutamine, and the human don't have enzyme to digest proline. Therefore, these peptides remain big. They don't are broken down completely. Therefore, these peptides are immunogenic to those patients who have a genetically susceptibility. So these peptides once they're secreted, they are partly digested in the lumen. They pass through either paracellular or transcellular route. Here is a TG, a transglutaminase, which deamidate the glutamine amino acid, and that becomes a positively charged molecule. As it enters the lamina propria, this is a foreign protein, therefore picked up by antigen-presenting cells and they have HLA, which are a negative charge. So this becomes, this picked up by APC, and then this presented to T cells, and then T cell leads to injury to enterocyte, and this cycle goes on. And in this bargain, we have B cells activation leading to antibody formation, and we also have some gluten peptide, which leads to innate immune system activation and damages enterocytes directly. So this is known, and much more detail is known about it. And so therefore, we can explore where we can target, what are the sites we can target for novel therapies in celiac disease. Coming first to that, we can gluten protein outside. You can use microwave or heat therapy to destroy these immunogen peptides. We can use different glutenases outside, and there are studies available that this enzyme present in many fungus. There's a glutenase enzyme. We can use this enzyme to digest it before we eat this wheat, or we can provide this enzyme called netiglutenase, which is an enzyme preparation which can be used, which can be asked, patient can take these tablets of enzyme, and therefore these peptides get, they are broken down to become non-immunogenic. The other target is that you can block jonulin, because this parasomal pathway, by using a drug called lesotretide. This is jonulin antagonist, and again we have phase 1 and phase 2 study available. Then we have a third path, which is you can block anti-TTC. Again, this is phase 1 study. We can block HLA2. We can block, and one important thing, that there are many targets which can induce immune tolerance in those people who have a high susceptibility to celiac disease. And the two targets there, one was vaccine, which is now found not to be useful, and other one is a gluten peptide, which also now being used in phase 1 trial. And in downline, we have a number of cytokine therapy available. So we have a lot many drugs are coming on the picture, and many of these drugs will be quite useful for celiac disease. So there are at least 7 or 8 targets are being explored. Many drugs are in the preclinical phase, some are phase 1, phase 2, and the most important, which I've highlighted in the red, that is enzyme therapy, which is very close. Then we have a anti-JOT, that is a lesotretide drug, and we have a immune modulation, the 3 targets which are important targets at this point of time. So recap, the celiac disease is a global disease and is as common in our country as in the rest of the world. It's a multi-system disease. We must recognize that celiac patient can come without diarrhea with many other manifestations. We should make a proper diagnosis. Many new biomarkers are on horizon. While we know the gluten-free diet is the only treatment available, but taking gluten-free diet is not easy, and there are many new targets are being explored. And now we have animal model, and which will also allow us to understand more about pathophysiology of celiac disease. With this, I'll stop, and over to Dr. Puri, sir. And my apology for taking more time than I was expected to. If I can stop sharing my screen. Yes, please. So you're muted, sir. So you're muted. So you're muted, sir.
Thank you, Dr. Govind, for giving a very extensive overview of the subject. The time is limited, so I am going to limit the questions to maybe 2 or 3 practical situations, rather than go into theoretical things like you mentioned in the last part of your talk about the newer modalities for treatment in the future. So I'm going to pick on 2 things. One is I'm going to ask all the panelists, and we have panelists from all parts of the country. Shobna Bhatia would represent Mumbai or West, Dr. Jayanti, the extreme southern part of the country. Dr. Mukevar, again, if there is a thing, then Midwest, although the term Midwest is mostly used in the US, but we can put him in Midwest. And also, if I see Dr. Ghosh somewhere, is he there?
Yes, sir. Yes, sir.
Oh, Dr. Jayant is there, so
yes,
more towards the eastern side. So let me start with the ICMR study. The principal authors were Dr. Rama and Dr. Govind, and we're fortunate to have Govind here. And briefly, what it said was that celiac disease is there everywhere. Although the limitation of that study was it was essentially a seroprevalence study. And unless you have the pre-test probability and you know the incidence of the disease, then serological studies can sometimes be off target. So I'm going to start by asking Dr. Jayanti. Jayanti, are you there?
I'm here.
Okay, so I'm going to ask you, do you think that, or do you feel, you've been in Chennai for many, many years, that there is actually celiac disease in indigenous South Indians, or if I can say Dravidian population of India?
I mean, basically, we are all aware that celiac disease is known in North India. So we are aware that it could be there in South Indians. We do, what I usually do is in my day-to-day practice, if I do get a patient with anemia or if I get a patient with some autoimmune disorders, I at least ask for a tissue anti-TTGA. That's the minimum test that we ask for. I think Malti had reported 5 patients, but they're all again from Rajasthan, and they were the ones who had settled in Chennai. So we have really not picked up even one case till date, although we get patients from Northeast. We do have patients who are working in the ITs, again from North India. So we're aware of it. We appreciate Rama's paper on this HLA-DQ2 and 8 that is almost equally prevalent in both North and South India. We're aware of that as well. So, I mean, basically what we do is probably do this, and most of these patients, we do have an endoscopic biopsy, which usually comes as non-specific duodenitis. So we don't have the classical villus atrophy. I've not seen so far.
Okay, so in summary, in the traditional South Indian population, celiac disease distinctly uncommon.
It's
if I
just
can
uncommon,
summarize,
yeah.
distinctly uncommon. Shobna, in 10 years, Govind has said that all over the world there seems to be a rising prevalence and an incidence. Does it apply for India? And for you, does it apply in Mumbai or Maharashtra?
So again, I echo Jayanti's view, and that is that the patients that I have seen are all from northern India. That is Rajasthan, Punjab, very few. I mean, I can actually count the number of celiacs I have seen totally in tens rather than hundreds. So I don't see as many celiacs, and we screen in the same way that Jayanti does. Any patient with diarrhea, any patient referred with osteoporosis, type 1 diabetes, anemia not responding to iron or vitamins, all these patients are screened. Even the patients with short stature are screened by our diabetologists or endocrinologists. But the answer is the same. The numbers we see are not as many as you see in the north. Whenever I've spoken to Govind, Ajit Sood, I think he's here today, or you all talk about an epidemic of celiac. It's not true over here. We have to actually make special effort to find them, and we still don't find them in the native population here.
Dr. Jayant Ghosh,
yes, sir.
You probably, if you can take the eastern part of the country and maybe even the northeastern part.
Sir, myself actually being a pediatrician, and then I did my DM in gastroenterology. So still now I'm practicing the pediatric gastroenterology also in Ranchi in Jharkhand. So I have many patients, pediatric patients who came with like short stature, failure to thrive, anemia, and later they turn out to be celiac positive. Not too much I have numbers, but I have different types of people I have seen. Like one patient of celiac who has later on developed CLD and
we won't go into the nitty-gritties and the case reports. Just stick to the general. So in the Jharkhand area where you practice, do you think that the prevalence of celiac disease is increasing? If you were there 10 years ago,
sir, I think so that it is increasing because yes, sir. I mean, like 5 years back, and now if I compare, then I think that it is increasing. Even in the tribal population of Jharkhand, I have seen 1 or 2 patients who are having celiac disease. So it is increasing here also.
I think we're running short of time. So the second question that we're going to take is, I'm going to ask all the panelists, in your practice, do you always take a duodenal biopsy for making a diagnosis, or do you go by the ESPGHAN, where they say if you have TTG more than 10 and EMA positive, then you can skip the biopsy? So Dr. Jayanti will go in that same order again.
We do take a biopsy because that will be the most confirmatory test. So I don't really depend only on the serological.
So your answer is always biopsy, right?
Yes.
Okay.
Yes.
Dr. Shobna?
Same
Yes,
biopsy.
we take biopsy. Yes, we also take biopsies, 4 biopsies from duodenum and 2 biopsies from the duodenal bulb. So total 6 biopsies. More the biopsies, more is the yield of the disease.
I agree with you, Dr. Shrikant, although I'm not a great fan of the duodenal bulb biopsy, because I think that if it is there in the duodenal bulb, it will jolly well be there in the D2 and D3 also. So leaving aside the bulb, Dr. Jayant, this question is specifically for you, because in my experience in Delhi or in the northern part of the country, I've come across several pediatric prescriptions where they haven't, where they've probably felt that it's not necessary, just on the basis of 10 times TTG and EMA positive. Sometimes they don't even have an EMA positive, and sometimes it's not even 10 times. So 6, 7, 8 times is also good enough for them to make a diagnosis. Your personal practice?
Sir, I always do biopsy to confirm the diagnosis.
I think that is the point I was trying to make, that the biopsy is essential. I personally do not feel that biopsy really can be classified as an invasive test. In that case, so is taking a sample of your blood is also invasive. So it is probably, nobody ever died from a duodenal biopsy. And the second thing, which is probably more important, is that should you be facing ever a situation of refractory celiac disease, then you don't know whether there is, you don't have a comparative biopsy that you want to see after 6 months or 1 year, more likely, then you don't have the baseline biopsy. So that is my prime reason why I think that each and every celiac should be biopsied, and that biopsy should be stored for good, and you should have a record every time you want to review that biopsy. Dr. Anil Arora is, if I can say, is giving me dirty looks. How much time?
I have a dirty face. I'm not giving you dirty looks in any case.
So that's the difference between Tweedledum and Tweedledee. Dr. Acharya, you want to add? Sir, how much time, please? How much time? How
You
much
can
time?
take another few minutes. No problem. 2-3 minutes.
How few is few? 2-3 minutes. Okay. Dr. Sood, since you've just come on the screen, may I ask you, how many, would you always take a biopsy, or there are some exceptions in your practice? Dr. Ajit Sood, question is for you. Please kindly unmute yourself.
Sorry, I'm Dr. Puri, I'm very sorry. I was on unmute. Can you please repeat the question?
The question is specific to your practice. Are there situations where you would not take a duodenal biopsy in making a diagnosis of celiac disease, whether it's pediatric or adult?
In pediatrics, less than 3 years, if 2 serologies are convincingly positive, maybe I avoid biopsy. Otherwise, I will suggest biopsy to all patients. Until unless patient refuses to undergo biopsy, that's a different situation. Otherwise, I still practice doing a biopsy.
So I think there's almost unanimity amongst all panelists that specifically where the adult celiacs, now adult would be anybody more than 16 years or so, the biopsy is essential and should be done, and that's the message that should go across. Govind, what is your, since you are, what is your practice?
Govind, unmute. Govind, unmute.
Govind, unmute.
Yeah, I always biopsy. There are many other reasons of doing biopsy. That is a lifetime diagnosis. So therefore, I practice only I treat only adults. Therefore, I don't have problem doing biopsy. But even for children, if the TTG is not strongly positive, always do biopsy because
No,
not
the question is whether it's 10 times. If that is good enough for children, would you still biopsy?
because this is a protocol at our place. I always biopsy unless there are reasons not to do biopsy.
I
Strong
agree.
reasons not to biopsy.
I think everybody's, but there's one.
Dr. Sitaram, can you take his comments from
Sure,
Nepal?
Dr. Sitaram, please. Dr. Sitaram, please unmute yourself. Dr. Sitaram, please unmute yourself.
Thank you.
Dr.
Thank
Puri,
you,
can I have a comment? Because after
Thank
Dr.
you, sir.
Sitaram.
Yes, yes. Actually, we also have the practice here to take biopsies. In Nepal, we are getting celiac diseases. Maybe because wheat is used like in form of momo and chow mein, and chapati also is popular. What we are seeing here is this prevalence of 1% concept. That means we should have 2 lakhs, 3 lakhs celiac disease. But maybe in hundreds, it is known to us. And the problem is in the adult population, these people are okay otherwise for years, and then they get these symptoms of chronic diarrhea and weight loss. And many times it is very difficult for the treating physician to even suspect. So high index of suspecting this disease is still not very common in the doctors. That problem still
Dr.
we have.
Sitaram, one question. The celiac that you see in Nepal, is it more in the Gurkhas or is it more in the Madhesi?
Well, suppose I know 5 or 6 patients of celiac disease. Most of them are these Indian culture people.
Yeah, so
You
Madhesi.
can call Madhesi, yes.
Madhesi, but so it's really not a.
And I think there is a balance. There is a balance. We have not studied, but I think it's not that part is not there. Whosoever probably is taking lot of wheats, they are having it.
Yeah, that's right.
Biopsy, we do it, sir. Biopsies we are doing because without biopsy, we are not.
Okay, we are running short of time. Thank you, Dr.
Sure. Thank
Can I
you.
have a last comment, Dr. Puri?
Dr. Shrikant, please come in.
Please. See, as per the biopsy of the dural.
Dr. Shrikant, we've lost your audio.
This is supposed to be patchy. In Murray, it was to take a dural biopsy, you increase the yield of the disease by about 10 to 15%. So that is why they recommended 6 biopsies. I have few questions to Dr. Govin. Do you have any Rio virus studies from South India and North India? Because considering the HLA prevalence, which is same, the gluten consumption of the South Indian people, which is 25 grams, is like a European people. So do you have any studies on the Rio virus that, because if you considered HLA, only 3% of the, that is question number 1.
No, we don't have any study. We don't have any study.
No study. There's no study on Rio in India.
Okay. And then the second is cardiovascular manifestations of celiac are increasing. And there are many papers of cardiovascular manifestations of celiac. Dr. Govin, are you?
There are some papers on those who have cardiomyopathy, but again, there are some papers say that there's increase by 2%, 3%, but again, some say there's no direct correlation. But certainly, we don't have big data set to really say that cardiomyopathy have a more chance of having celiac disease.
Govind, one more point, the one about iron deficiency anemia. So iron deficiency anemia in the West is very different from iron deficiency anemia in India, and specifically in the lower socioeconomic status. So we have a paper with UCMS pediatric department where they had, I think just about the sample size was 100, and 100 patients of iron deficiency anemia, only 5% was celiac. So in India, it would still be the parasitic infestations, etc., would come much higher as compared to celiac disease. So celiac disease, even in children, the commonest cause of IDA would not be celiac disease in India, whereas because there's practically complete absence of parasitic diseases in the West, in North America and Europe. So it's different. You can't compare North America with India, especially the slum areas, because this study was done in East Delhi, more towards, where there's a lot of slum areas. So that is another point that I wanted to make.
That's agreed true, sir, because not every anemia will have celiac disease. So again, you said 5%. Our study of 100 patients, 10 had celiac disease, certainly the tertiary care center, referral bias of more refractory cases. But even the study from US said 1 in 31. So it means of 100, just 3. We are 5 or 10, they're just 3. So it means, and this is a treatable cause, it's a curable disease. So you won't like to miss celiac disease if someone comes with anemia.
Absolutely, but again, the point is the pediatricians, they stress that it's going to be nutritional anemia, and parasitic infections would come higher than celiac disease. That's the bottom line. So I think everybody would agree with that.
I just want to add one point. The term like nutritional anemia is really misnomer. I don't think we should use nutritional anemia because nutrition occurs because either a person not eating, there's no food available, or GI tract is dysfunctional. If somebody had normal food, if somebody has intake is good, then if there's anemia, then GI tract is to blame for, if there's no other source. So term nutritional, I don't think only in textbook writes nutritional anemia, and this is how we confuse, but there has to be cause for anemia. Like parasite, there's a cause. There's a hookworm, there's a cause. The most important cause is there's no food to eat. That's perfectly fine. But if there's good food to eat, if there's anemia, it's always a pathology. And GI tract is, majority of the time, is a disease.
No.
So just a quick...
David, I would, before Dr. Bhatia comes, I just want to make the point that in slums, malnutrition is so common that nutritional anemia goes hand in hand with malnutrition. Shobna.
So that's the same thing. Gut dysfunction, because of microbiome, poor microbiome, poor hygiene, gut enteropathy. That we know that there's enteropathy, what's called environmental enteropathy, earlier it's called tropical enteropathy. So that leads to poor absorption, but that's not physiology, that's pathology.
So, but Govind, the same thing that in many communities, they don't eat green vegetables for about 3 to 4 months. And that's why, and their food is mainly, the dals and the rice, which do not contain much iron. So they are the ones who are likely to have iron deficiency. The second point I had is more from the paper that you cited, where if people did not have wheat in the first 2 years of their life, then in that case, their incidence of celiac was slightly low. Do you think we should move towards that?
I'm not sure about this. This is still under debate. There are studies available. In fact, the wheat intake at the time of, say, 100% is a area for research that 3 to 6 months. People say never give any antigen before 3 months. So keep
6
them.
months is what people are.
3 months at least.
I think 6 months is
6
the time.
months is what everybody's recommending.
What everybody says.
Yes.
Dr. Anil, can we wind up now? Or?
Yeah, I think yes. Well, we are going away from celiac to nutritional anemias.
Yes.
So, okay. So thank you, Anil, and congratulations on this fantastic endeavor.
Thank you.
Yes. Thanks, Anil, for involving us. And thank you, Dr. Puri.
Thank you, sir.
I'm thankful to Professor Puri and Dr. Govind for their excellent presentation. And I'm sure listening directly from a horse's mouth is a treat. And as a tribute to that treat, we already have 3,300 people across the globe who are listening to your talk. I'm really thankful to all the speakers, moderators, and the expert panel members. With that, we formally come to the end of this session. We move on to the fourth session of the day. That will be chaired by our flamboyant moderator, Professor S.K. Tyagi from Meerut, who needs no introduction, other than the fact that he's a brilliant academician. He is one of the best speakers we have in our fraternity today, and he's going to take over the task of moderating the session on very important topic of fecal microbiome and the fecal transplantation. These presentations will be made 10 minutes each by Dr. Rupa Banerjee, who's going to talk on gut microbiome, followed by Dr. Ajit Sood, who's going to talk of FMT. Over to Dr. Tyagi, please.
Thank you, Anil. Thank you very much. I was looking at the screen for the previous session, and it was such a pleasure to see all these faces: Shobna, Rupa, Ajit, Dr. Anand. We used to meet them every week at some conference or the other, and now we meet them virtually. So thank you, Anil, to give us an opportunity to at least see how well everybody is and refresh our memories regarding their faces. And you've already introduced the speakers. I have two excellent names and very well-known names in Rupa, who's from the AIG, and she especially runs the clinic on IBD and now on fecal and FMT. And of course, Ajit, who's multi-talented. He's done a lot of work on hepatitis C epidemiology, on IBD, and now on fecal microbiota and fecal transplant. So with these two speakers, I can't really go wrong in my moderation. And as panelists, I have Professor Anup Saraya from the All India Institute. I have Parimal Lavate, who appeared and disappeared as fast and as silently as he normally does, but I'm sure we'll be able to catch hold of him. We have Dr. Ayal Acharya from Nepal, and that adds a little bit if we consider Nepal as a foreign to us. We are the same culture, foreign element to this panel. And of course, we have Sirihari Anikinde from Delhi and from Sir Gangaram. So with that, I don't think we've already, a lot of our time has been stolen by the previous session. And I was afraid that when Ajit was being asked questions, whether my speaker will also be stolen. But fortunately, we held on to him. So without giving anybody an opportunity to do that with our talks, Rupa, I now request you to first talk about the gut microbiome, and then of course Ajit to talk us through FMT. 10 minutes each, and then we get on to questions and from the panelists, and I'm going to ask them a few questions to clarify. And of course, for every question that I ask them, their opinion, I request the two of you to also give your opinions on them.
Good evening, everybody. Thank you, Professor Arora, for giving me this opportunity. And as Dr. Tyagi said, it's actually still nice to see everyone from the little small windows in this Corona times when we are all leading restrictive, to say the least, lifestyles. So the talk for me is gut microbiome and recent advances. And in 10 minutes, we'll just get a glimpse of what is happening and how it is going to change our practice in future. So we know that the human microbiome is an ecological community. It is a part of us. And Lederberg said as late as in 2000 that we are actually ignoring that it could be one of the major determinants of health and disease. Things changed over the last few years. We are now realizing that we are more bacteria than human. Healthy adult harbors 100 trillion bacteria in gut alone. This is 10 times the number of human cells we possess. Humans possess 23,000 genes, and if you thought that was huge, the microbiome contributes 300,000, just to highlight how important that is. The communal gut microbiome is actually 150 times larger than the human genome, and hence it is important. The last decade has seen a rising interest. There are things that we know now. We know that the luminal surface of intestines contain billions of live bacteria, 100 times higher than the number of cells in an adult person. Based on targeted RNA gene sequencing, we know that there are different types of phyla. 4 major types, that also we know: Firmicutes, Bacteroidetes, Actinobacteria, and Proteobacteria. And that's, of course, a simplified version. A complete and balanced bacterial ecosystem forms due to optimal interactions between these different bacterial phyla, and any imbalance on that leads to disease. Now, how did we know so much about the microbiome? And I think all of us in the GI community now need to understand that how are we progressing. So first, we identified which microbes are there. So we got to the nucleic acids, and then we could do the ssRNA approaches. Then we needed to know what are the microbes doing. So we studied the RNA, metatranscriptomics. I think these are terms we slowly will need to get used to. The proteins, metaproteomics, the metabolites, metabonomics, and what is the genetic potential, the DNA, the metagenomics. Now, once we had all this, we also learned that there are different factors beginning from genetics to birth route to geography, stress, diet, drugs, anything which can alter the gut microbiota. Any perturbation can actually cause infectious diseases, metabolic diseases, and inflammatory disorders. And if you see here, this is the entire spectrum. The metabolites from this gut microbiota, when there is a dysbiosis, the inflammatory cytokines, they all can cause numerous disease. And if you can just see the whole list, other than the local, which is the IBD, the irritable bowel syndrome, the GI cancer, so on and so forth. So what are the recent advances? Now that we know that basic, we need to move from bench to bedside. We've been busy in the bench for quite a few years trying to identify, is there dysbiosis, how to identify. And now that we know, I actually, to put a glimpse, highlighted a few areas and what changes are slowly happening, because as gastroenterologists, we need to know what is the future. So it's fairly well known now that obesity and microbiome, there are differences. For the interest of time, I won't get into the details, but there are alterations in the gut microbiota, the inflammatory markers in the obese, which is distinct from the normal or non-obese. So there was this interesting study. Dr. Sood will cover fecal microbial transplant, but these are oral capsules, and they were given for treatment of obesity. And why was it done? Just to know whether oral microbiota transplantation could really make us trim and non-obese. Initial results, as you see the light green that I have marked it, that it is suggesting, of course this was a small study, small numbers, it is suggesting that possible improvement in metabolism after fecal microbial transplant. The next big thing is antibiotics. These are fundamental, often life-saving modalities, but if you see, India is high on antibiotic usage, one of the highest in the world. The balance between the overuse of antimicrobials and the clinical need in these situations is often difficult to understand. And that is what we struggle with. So they say don't give antibiotics early on in life, later on metabolic diseases are more. But what about H. pylori? We are giving multiple antibiotics, and that is a dilemma. Eradication reduces recurrence of peptic ulcer and incidence of gastric cancer across Asia, if not so prevalent in India. However, we are concerned whether that causes antibiotic resistance. Does that perturb the gut microbiota? And of course, the development of metabolic syndrome after H. pylori eradication. So this elegant study has come in Lancet, and this is on 1,620 patients given eradication therapy. Fecal samples were collected before treatment at 2 weeks, 2 months, and 1 year after therapy. ssRNA, 16S-RNA analysis was done, and it was assessed for long-term outcomes. What was the reinfection frequency? Did it change the microbiota, the antibiotic resistance, and metabolic parameters? To cut the long story short, the interpretation showed good news that H. pylori eradication had minimal disruption of the microbiota for about 2 weeks and got restored quite early. There was no effect on antibiotic resistance of E. coli, and some positive effects, trends towards positive effects on metabolic parameters. So the results support that we can maybe are looking for long-term safety of H. pylori eradication therapy. From microbiota research now to its clinical applications in IBD. If you see, what is the clinical potential of gut microbiota in IBD? First, as a diagnostic tool, can we differentiate between healthy IBD, IBS? Can we predict response or no response? And of course, as a therapeutic tool. There are many studies coming in this area. I have selected just one or two few which have come in the last 1 year or even this year because it seemed interesting. So the first is clinical and biological predictors of response to standardized pediatric colitis therapy, the PROTECT study. Now we know that children with ulcerative colitis actually have much more severe disease, and up to 26% actually require a colectomy within 5 years. Now all this time, we, as a predictor of severe disease, we used initial disease severity, lack of response to early therapy, low albumin, anemia, vitamin D, and so on. But despite that, there was variability in treatment response. This was a study of 428 treatment-naive children with ulcerative colitis, and this looked at the gut microbiome before treatment and association with clinical outcomes to develop a predictive model of disease. This is the predictive model, and it showed that microbiota or the composition of microbiota actually affected the corticosteroid-free remission, who will have corticosteroid-free remission at 52 weeks, and who will not respond and go to escalation therapy with anti-TNFs. So there were these significant results. The Clostridia were increased in patients who responded to steroids, decreased in those who needed anti-TNF. Therefore, it showed that an antimicrobial peptide gene signature, abundance of ruminococci, abundance of Saturella were actually associated with improvement and a favorable response to pediatric ulcerative colitis. So what's new here? It just tells us that microbial factors in the gut could actually improve prediction of response to initial therapy. This gives us an idea that now novel therapeutic targets we have. If we know that this particular bacteria or phyla is important, can we give that selectively? And helps develop personalized approaches to improve outcomes. Similarly, this is another study between enteral nutrition and steroid-based induction therapy. Here again, it is found that enteral nutrition was showing much higher mucosal healing, 89% versus the steroid group, though clinical remission was the same. Now, how did that happen? Perhaps because in enteral nutrition, the Clostridium species increased, the Fecalobacterium came down compared to that of corticosteroid. This is the third one and the final paper that I wanted to highlight in gastroenterology this year, because this is very close to the heart. Can we, rather than drugs, probiotics, chemicals, have a diet for microbiome-centered therapy for IBD? For time constraints, we'll just rush through these slides. This just shows that if there is a diet which favors SCFA producing bacteria, and it has been tried, it can improve the inflammation. So the aim was to define diet microbiome inflammation interaction that promote health while consuming the IBD aid, that is what it is called. So it was a single arm prospective study, 19 patients only, but with ranging from mild to severe CD and UC. After a baseline period of 4 weeks, there was a dietary intervention for 8 to 10 weeks. Most patients actually were at least 50% diet compliant. What were the results? It just showed, and I'll just highlight one or two, that vegetable and nuts increase the production of butyrate producing rosiburia. So now we are getting into the phase when we can say what the roti will increase, what the gobi will bring it down. So we know which vegetable, which nuts, which probiotics foods are impacting which microbiome. And that is the most interesting part of this study. Not only that, they identified a typical PGP expression, which could be a novel molecular biomarker of the diet microbiome immune interaction. So you give a diet and you see how the PGP expression varies. That will allow us customized dietary guidelines to emphasize foods with known effect on microbiome signatures. And this is the future. This is what we are looking at. So current microbial therapeutic options are simple: indirect modulation by diet, enteral nutrition, prebiotics, accession by prebiotics, again, uncharacterized community, transplant, fecal transplant, reduction with antibiotics. And this is how the future and future perspectives will look like. There will be live biotherapeutics. There will be genetically manipulated strains that we can use. There will be next-gen FMT with standardized protocols, small molecules, oligosaccharides, personalized dietary manipulation. And that is going to be the future of gastroenterology and treatment. But my best is the food. Your food is your best medicine. What else can be? Just make the healthy choices. Microbiome-based dietary modification and therapy is just around the corner. Novel biomarkers may help identify the best food for the best microbiome. Thank you. And
thank you, Rupa. Thank you so much for that meta-rupomics. You know, these terms, I'm really remarkable that you could get through all those terms without twisting your tongue too much. And so that was great. And the best part
I hope
of
I
it,
maintained time.
I know you maintained time despite all those difficult words that you used. And it's so encouraging to know that diet would be the next good thing. It's definitely more palatable than the next topic that we have from Ajit. That is the fecal microbiome transplant. And of course, for everything from obesity to IBD, from myocardial infarctions to what you have, this is the fashion.
So we are now working actually on, before Dr. Sood takes, we are actually working on now an Indian diet, which will alter the microbiome and characterizing it. It's interesting, sometimes frustrating, and a lot of effort, but I hope those will give us simple answers for a country like
yes, a lot of effort in designing that, and Dr. Sood is going to tell us about a lot of effort the patient would have in accepting that therapy that he's going to talk about. Dr. Sood, that was in lighter vein. We are eagerly waiting for you to tell us about something that appears simple, but it really is not, and has tremendous therapeutic implications as of now.
Thank you, Dr. Tyagi. Rupa has highlighted how gut microbiome is important for health, and any dysbiosis can result in many diseases. Once we have a knowledge that dysbiosis can result in various diseases, it can be manipulated by different ways to put it back to as normal as possible. The various ways which can be used for therapeutic manipulations of the gut microbiome include diet, as we've been emphasizing, prebiotics, use of probiotics, antibiotics, and of course, FMT. FMT refers to infusion of fecal suspension from a healthy individual into the GI tract of another person for a therapeutic benefits. There are various diseases for which FMT has been tried or is being tried, including Clostridium difficile infection. That is the number one situation where there is an established role of FMT. Other intestinal diseases include inflammatory bowel diseases, irritable bowel syndrome, the liver diseases like alcoholic hepatitis, hepatic encephalopathy, metabolic syndromes, obesity, various neurological diseases like multiple sclerosis, autism, and another important situation where we can think of using FMT is actually to eradicate multi-drug resistant organisms. Now I'll go straight to the indications. C. diff is one for which there is a most convincing evidence, and the FMT has got entry into the guidelines. Both NICE and European guidelines mention that it has a definite role in this. And their recommendations are that FMT is recommended as a treatment option for both mild to severe recurrent C. diff. Its implementation in clinical practice is recommended. The quality of evidence is high and the strength of recommendation is strong. It shows that C. diff is being now, for C. diff, treatment with FMT is being recommended by the standard guidelines. How do we do FMT for C. diff? One, that we can use FMT as a sole therapy, or we can still combine it with use of antibiotics. We can use it as a sequential therapy. For example, we can use for pseudomembranous colitis, we can use antibiotics till the time pseudomembranes are present. Once pseudomembranes disappear, FMT can take over. Or otherwise also the fidaxomicin or FMT sequential therapy has also been tried and found to be effective. Overall, there is more than 90% cure rate, which is very, very high figure. And there is a significant decline in C. diff disease with FMT, both in patients with severe and in fulminant C. diff. Now it brings to a question that is FMT useful for all patients with C. diff? Can it be the first treatment for patients with C. diff infection? And I would like to say here that C. diff is becoming more and more common in our day-to-day practice. We are seeing more and more number of patients with C. diff because we are doing both GDH and toxins with the high suspicion cases. Now, at the moment, if you say that this is the first therapy, the data is not very convincing because the use of antibiotics is nearly as effective as FMT if we look at as a primary therapy. So at the moment, we can't recommend FMT as a primary therapy for patients with C. diff, but it's recommended for patients with recurrent or refractory C. diff. Now this was about C. diff. Now coming to IBD. Dysbiosis is known to occur in patients with IBD, but the situation is much more complex in IBD compared to C. diff. We have cities available for induction of remission in patients with ulcerative colitis. The two trials are from Australia. One is from Canada and one is from Netherlands. Overall, the number of total patients included in these 4 RCTs have been 277. There has been a significant advantage shown with FMT in achieving clinical remission in these patients. There was marked variation as far as frequency and the route of administration of FMT is concerned. The main indication for FMT in all these 4 RCTs have been mild to moderate ulcerative colitis, and these patients have been followed for 8 to 12 weeks. Now, when we look at the results, as I mentioned that nearly 40% of the patients, or precisely 38% patients, achieved clinical remission when we assess the response in total to 77 patients compared to around 18% with placebo. But if you look at the trials individually, out of 4, 3 trials shown a convincing evidence in favor of FMT, while one trial where FMT was used through oral route was not very much in favor of FMT, and the study was terminated prematurely. So based on these 4 RCTs, we have a Cochrane analysis available in 2018. The recommendations were that at the moment, mode data is required before FMT can be recommended as a therapy in clinical practice. They observed because there's a marked heterogeneity in the RCTs. So at the moment, the data cannot be taken as robust enough to recommend FMT as a standard of care for ulcerative colitis. Now, we've been using FMT, and what we realized that steroid-dependent ulcerative colitis is a very commonly encountered situation, and we don't have many options for these patients. So we selected this group of patients, steroid-dependent ulcerative colitis. We had 49 patients where we used FMT as a multi-session colonoscopic approach, and we found that 45% patients, they could achieve clinical remission within 6 months. We had a 7-session colonoscopic protocol, and steroids could be tapered off in all these patients, and because the clinical response was there at least till 24 weeks. Now FMT, when we use, like any other manipulations which we do for correcting the dysbiosis, we know that the gut microbiome is very resilient and the changes are not permanent. So we don't expect that whatever benefit happens is likely going to be very long lasting. And then we evaluated whether there is a role of FMT in maintenance of remission. And this is the first study reported in patients with maintenance of remission in ulcerative colitis. Here we took those patients who achieved clinical remission with FMT, and we continued these patients either on 8-weekly FMT or placebo. And we found that a higher number of patients achieved clinical remission while being on FMT, though the number was not statistically significant, but there was a significant difference when we came to endoscopic remission and histological remission. So this highlights that there is a role of FMT in maintenance of remission in ulcerative colitis. A step further, we evaluated the clinical predictors of response to FMT in ulcerative colitis. Now we evaluated various factors like age, disease duration, disease severity, extent of the disease, and endoscopic severity. And nomograms were developed for prediction of probability of achieving remission in these patients. What we found that age, disease extent, and endoscopic severity have a significant correlation when it comes to prediction of response or probability of achieving remission. The increasing age has a negative impact. Higher endoscopic severity, M3, has a negative impact, while M2, Mayo Score 2, has a positive response, and extent proctosigmoiditis patients does better as compared to pancreatitis and proctitis. So the conclusion, though, our observations show that a young patient having proctosigmoiditis, moderately severe disease, is more likely to respond. What we could not do in our study was the microbiome analysis of the donor and the recipient. This is a very important aspect because there is a possibility that the chances of engraftment of donor's recipient microorganisms will be correlated to the recipient's microbiome. We have evaluated the acceptability, tolerability, and the safety of fecal microbiota transplant in our country, and the patient's acceptance is fairly good. More than 80% of the patients, they accept FMT as a therapy because they have been so much disturbed by various other therapies. The main short-term side effects being abdominal discomfort, flatulence and abdominal discomfort, and low-grade fever at times. The long-term follow-up of up to 1 year showed that 8 patients had effects like urticaria, arthralgias, arthritis, or depression. 1 patient had allergic bronchitis and partial hearing loss, which seems to be unrelated. So this was about IBD. Now coming to irritable bowel syndrome, there are 2 RCTs available in 2020. The response is mixed. I mean, one says it works, the other says it doesn't work. To keep this meta-analysis for us plot shows that at the moment we cannot accept that FMT is very effective for irritable bowel syndrome, but to keep the debate alive, another meta-analysis has appeared in American Journal last year, which again showed that it does not go in favor of FMT for IBS. But a recent article in Gut from Scandinavian countries has shown that FMT, when we use it periodically, initially, and then at 12 weeks, it might have a beneficial effect. So still the debate is on whether IBS could be an acceptable indication or not. In liver, this is the phase 1B trial, and in which it shows that when we use FMT as a capsule form, the chances of HE and infections resulting in hospitalizations may be less in patients who are on FMT capsules compared to placebo. But this is phase 1B trial, and there are 2 studies from India by mainly Abby Phillips and Dr. Serene's group, in which they documented that FMT might work in patients with severe alcoholic hepatitis. Now, what is the way forward? Now we are moving from crude FMT preparations to better techniques. It's more of automation and next generation FMT, and we are going to depend more on scans, and we are depending more on now metagenomics, metabolomics, because this is how we are going to identify not only the presence of the organisms, but their functionality also, because that is more important. Now, regarding advancements, we are advancing towards the route of administration also. Now, the capsules are also available. The capsules are available for C. diff. The capsules have been used for patients with ulcerative colitis as well. But this is only in the initial phase, phase 1 trial only. But there is a hope that capsules might also work. Now, coming from FMT to SMT means selective microbiota transplant. I mean, there is a hope that selective microbiota transplant might work. And this is the first study in which microbiome, the first study where microbiome has been used as a drug. The spores of Firmicutes have been given in the encapsulated form. The 2 things which have shown benefit, that if we treat these patients with antibiotics, with preconditioning with vancomycin, and if we give these capsules every day compared to a 7-day therapy, the engraftment of the organism is better. In long-term clinical use of FMT, still there are many questions which remain unanswered. Like if we see that what really matters when we use FMT, the attributes could be related to the donor and the recipients and to the FMT procedure. The main attributes related to the donor recipients are the patient selection, the donor selection, the compatibility between the patient and the donor, and the stringent donor screening. How often and how to do efficient screening. The FMT related attributes are the fear of transmission of unknown infections and unknown diseases. We don't know what will happen after 5 years, though we are getting data after 1 year or maybe longer after C. diff use. The acceptability in the long term, the duration of therapy, and the frequency of therapy, whether it differs for patients for induction of remission, for maintenance of remission, and whether it can be used prophylactically. So these are the attributes based on that. So at the moment, I'll say that FMT, we cannot say at the moment that this is a standard of care, but it's like that I may not be there yet, but I hope to be there in near future. Thank you.
Yeah, you have to unmute Dr. Tyagi. Dr. Tyagi, you will have to unmute yourself. We are not able to hear you.
Unmute. I am unmuted now.
Yeah.
I never could imagine that I could be muted, and therefore I didn't look at that part of it. Nonetheless, that was a brilliant exposition on FMT, Ajit. That is very nice. 2 words have been used rather frequently in both the lectures, and that is dysbiosis. I'll just get back to a very basic as to what exactly is dysbiosis. Is it the change in the phyla, or is it in the numbers of the microbiomes? And are there simple methods of diagnosing dysbiosis?
When it comes to phyla, I mean, there basically the microflora constitutes 90% of the microflora is represented by Firmicutes, bacteroidetes, actinobacteria, and proteobacteria. Now, among these, Firmicutes and the bacteroidetes, the ratio changes, and there's increase in proteobacteria, which is considered more pro-inflammatory compared to Firmicutes, which is considered anti-inflammatory. So this is one. The second is that alpha diversity is also low in patients who suffer from various diseases. So it's both the richness and the diversity which matters. Actually, it's the ratio of Firmicutes to bacteroidetes which undergoes change in these patients.
And any easy way of diagnosing this at the moment?
Like Dr. Tyagi, you might have noticed that we have done 3-4 trials, but we've still not been able to come up with the data of microbiome. We've really been trying very hard.
It's really huge, actually, and so diverse that it's really a...
The culturing technique is not good enough. The culture is not good enough. Now we are, you can say, we have taken a few steps towards analysis of the microbiome. Luckily, we have the stool samples preserved with us, and hopefully we will come up with the data. We are working on microbiome profiling of the donors as well as the recipients. But there's no really...
We are doing some 16S RNA work. So what we do is storing, instead of storing the stool, what, as Dr. Sood said, these are all in the stages, but we isolate the stool DNA and then store it. So the retrieval is much better. Our experience was that when we keep stool for too long, then when we try to retrieve the DNA, the yield is poor. If you can store the DNA, the issue is you can, sequence the gene. That is not the problem. But interpretation, the bioinformatics part of it, that is what is difficult. But there are now some organizations, you can outsource it, they will get it done. So,
Rupa, how disruptive are antibiotics to this microbiota? And do prebiotics and probiotics at all help us in this manner?
I think this is a very good question because, see, this is an evolving area. So there was a stage when anybody, we know that antibiotics do disturb the... So we know that antibiotics do disrupt the normal flora, and then it takes time for it to recover. For a normal person, that happens. There was a time when everyone given an antibiotic used to take that probiotic with it, together with it, as if, that will replace the healthy bacteria faster. It will, of course, enhance immune function. It will reduce yeast overgrowth. And all this was what we thought. But now that is changing. In fact, studies are showing, and when a journal like Cell highlights a paper, they're showing that indiscriminate use of probiotics post antibiotics is not warranted because it may in fact delay the restoration of the normal gut microbiota, because again you are putting in some strains in higher numbers than others. So these are all trends. So it's not like for everything probiotic. I think that it's the word of caution has to be there. We are using probiotics as if it's a panacea for all illness. Just take a probiotic and they take it for months and years. I think that has to stop. The more we know the microbiome, we'll be in a better position.
Yeah, Dr. Tyagi? Yes, sir.
Yes.
Dr. Tyagi? Can I put up a question to Dr. Sood with attention to Dr. Rupa?
Of course, of course.
Fecal transplant on average gives 60% response, and it's not effective in all cases. And the purpose of fecal transplant is to provide, as you said, Firmicutes, bacteroides, and also to decrease the population of Actinobacter and Proteobacter. Would you like to screen the donor for these bacteria before you transplant? And which is the best part of bowel where if you infuse gives the best result? Is the ileum or proximal part of colon?
Yes, I think very vital questions, very vital questions. If I could just make a brief comment about antibiotics. The antibiotics have been reported to alter the microflora, and the effect is seen to last as long as 3 months. It depends what dose and how long or what combination of antibiotics we use. The disadvantage being that it kills all bacteria. About probiotics, because at the moment we are not sure it is just the bacteria which works. We are totally ignorant about the fungus, fungome, and the virome. I mean, there are studies even with C. diff which have shown that a stable virome may actually be the one which helps in maintaining the bacterial flora. So we don't know the exact role of fungus and virus at the moment. That's why probiotics may not be as effective as FMT. Because metabolites, we can't say.
I agree. In
That
fact,
short-chain fatty acids and bile acids, I mean, the role could be there. This is an open question at the moment. We can't say. About Dr. Acharya's question that FMT, that donor screening is very, very vital. This is a question for future. That when we come to precision medicine, it might come to that whether donor and the recipient are compatible or not. Now, if a recipient is totally deficient in a particular strain, even if we give it in the FMT, that recipient is not likely to sustain the organisms. It is known that if there are bacteria, it may be in a lower concentration. If we infuse this bacteria, like maybe the healthy Firmicutes, that is why now it's coming to Firmicutes or Bifidobacterium as a select organism in UC. So donor and recipient matching is important. Now, the concept of super donor, I have my doubts about the concept of super donor. I think actually super donor may boil down to actually a better match between donor and recipient.
Dr. Anu, Dr. Saraya, you have in your department an experience in FMT. Would you like to add anything that has already been said?
Nothing much as such. They have already discussed.
Well, that's an answer which people like me give. You know. Anyway, to Dr. Anu and to Rupa and to Ajit, I mean, normally this question that I'm asking happens in the very end. Has this pandemic made a stop to all work on FMT, or is your work still carrying on? What I mean, Dr. Saraya, is what is the role in transmission of such viruses and pandemics which we are little known about while we are doing this?
Actually, if we see during this pandemic, what is the role of FMT as such? This is a definitive therapy for CD Clostridium difficile infection when it is refractory to treatment or recurrent. So then in this subgroup, we have to assess risk and benefit. Whether this is life-saving, because in pandemic, we are postponing certain procedures. This is also a gastroenterological intervention. So if it is absolutely mandatory, especially in CDI, where the risk is less and chances of benefit are more, we can advise FMT. But the problem is that even FDA is saying that those products which are collected before December can be used, and now they are also not advocating FMT. Now, here comes a question. You see, more than 300 trials registered on FMT, and so we are not sure whether we will have benefit in many other conditions except CDI. So we are giving FMT in clinical situation and in trials. So as far as trials are concerned, my opinion is that we have to discuss with the regulators, we have to discuss with the funding agencies, and we have to discuss with ethical committee. And for the time being, till such time, we are not in a position to screen donors adequately. There are no standardized protocols for donors also at the moment in place in various places. So there we have to put a stop on trials, ongoing trials. That is my opinion. And secondly, in clinical situations, as we know that this is still experimental therapy in many conditions. So there also we have to go slow. We have to screen donors, and as far as route is concerned, that also we know that in certain situations, especially in gastroenterology, whatever interventions we are doing, these interventions can lead to aerosol generation. And so we are putting our healthcare worker at risk, and we are putting even patients are at risk. So these procedures like endoscopic procedure should also be avoided. As far as route of administration is concerned, as Dr. Sood has said, that we are now moving towards a form like capsule which can be given, but that is not available everywhere. So till such time, if we are giving through endoscopic route, if we are, suppose we are placing a tube, we all know that these viruses, they stay in nasopharynx. So that can lead to aerosol generation, and that can also transmit infection. So these precautions we have to take. We have to avoid interventions unnecessarily, and we can use this therapy in a specific clinical situation, especially in recurrent or refractory CDI. That is my opinion.
I think there is a British Society of Gastroenterology guidelines which has just been published on FMT during COVID.
That guideline, in fact, that has appeared in gut, and there also they have put a lot of restriction, and they are saying that it should not be done.
So
in
they are
many
also not recommending, but in case, I mean, what he said for anybody who wants to read it, it is quite well characterized. As
actually, those guidelines, in fact, are also based on their observation in the initial stages till March.
Yes.
So a lot of water has flown under the river now, and we have to revise those guidelines, and a lot of data has been generated over the last 3-4 months. We have to analyze that data, and then and only then we can give any further.
I agree with Dr. Anup totally that till the time we can actually check the donors for the virus in the stool, we can't use FMT. Our program has come to a halt, and I'm trying to convince people that if they could test a donor's stool for virus, and once it's documented that it's negative, only then we should proceed with the regular trials. Even I was thinking whether a nasopharynx twice being negative still doesn't say that the virus cannot be there in the stool. So we are not using FMT for last 6 months. We are just waiting that if we can have a stool analysis for the virus, we can proceed. I totally agree with Dr. Anup Sarai.
We are not doing it.
Yeah, I think Dr. Tyagi possibly has lost the link. So maybe also involve other panel members.
Dr. Rupa, can I put up a question?
Sure.
You said good remission with enteral feeding. What are the constituents in the enteral feeding? My impression is that the Western diet containing lots of fat and high carbohydrate diet, milk products, and even gluten-containing diet worsen inflammatory bowel disease. On the other hand, some anti-inflammatory drugs as available in the East, which I have something. I hope you will allow me to present in one of your proceedings in AIG. Diet plays a major role. And what are the constituents in your enteral feeding, which gave relief? You mentioned in your lecture.
So these enteral nutrition here is primarily for pediatric cases and sometimes for small bowel, extensive small bowel involvement. They primarily work via SCFA. And actually, we've already seen that for pediatric Crohn's disease, enteral nutrition is preferred to all other forms of treatment, even for steroids. What has happened now is different. We didn't know why. So now it looks like that enteral nutrition, develops a favorable bacteria population compared to corticosteroids or other drugs. And I completely agree with you that diet is a new area. Now with microbiome getting so much importance, us understanding microbiome better, that will be the way forward. If we can have a preventive diet to prevent such inflammation, but that is too early to comment now, but we are definitely on the way. And I think Dr. Sood will throw more light. Yeah.
Just
Can I
one
just,
question. I know,
Dr. Sood, can I just
can I just make one comment?
Yeah, 1 minute. I think Dr. Ajit, other panelists have just not joined. Can you please request Dr. Parimal, Dr. Shri Hari to have a comment each before you finish?
Okay.
Because Tyagi is not.
Right.
I
No,
have two comments actually. One is if you look at the animals like pets which we have at home, for them their toilet paper is the tongue. And to me, I think they are doing a kind of fecal microbial transplantation on day-to-day basis, because they clean their stools with their own tongue. So you have any thoughts on this and how it may be really affecting? Because this is a very thought-provoking thing.
During the World War II, and the Bedouins of China and all, when they had diarrhea, they were just given camel dung to eat. The concept of fecal transplant actually came from those early studies that camel dung, and then ulcerative colitis, pig intestinal extract used to be given. So this is, I'm talking more than 100 years ago, and it used to work. So I completely agree, but whether we can do the same, I think
I am not proposing that we do it. I am asking whether those animals are protected
But in fact, I think we should change the term from fecal to make it microbiome, so that acceptability for us doctors as well as the patient will be different. And once we process it, the main part, the smelly part of the stool is not there. So I think we should call it microbial transplant rather than fecal transplant.
And the second comment on a lighter note which I had was about irritable bowel syndrome. So I think although FMT has been stopped, if you have a difficult irritable bowel syndrome, it may work either by threat.
This will be autologous transplant.
Feeling better.
Animals are using it. This will be an autologous. This may not change the microflora because it is going to be his own stools. So it is actually an autologous, which has been used as a placebo or as a therapy for some people.
Dr. Sood, on a lighter note,
in one trial they used it as a autologous transplant. The study from Netherlands, that was not a successful trial. No, I'm just thinking about this, whether the animals really are.
Kindly do not take stool from an obese person, because you give an obese microbiome to a thin person and post-transplant becomes that obese IBS patients, you had it. So I think that's on a lighter note. I think Dr. Anand, we want to hear from you. You have to unmute yourself.
We
have a next session. We are going to discuss that point as well.
If I can make a quick note on the role of antibiotics that we were just discussing, and why FMT works better in C. difficile colitis. So basically, what we were actually discussing is something called resilience. So what is resilience? Is basically it is a property of the microbial community that defines how fast and to what extent it will recover its initial function or taxonomical composition after a perturbation. So basically, the perturbation or the resilience of the microbiome, it basically depends on two important factors. One is the nature of perturbation and the composition and the diversity of the native microbiome that is present. So if you have a short-term perturbation, like giving an antibiotic for a short period of time, that is called as a pulse perturbation. So if you give an antibiotic for a short period of time, there has been a recent study which has been published from Birmingham, which involved 12 patients, and their native microbiome was assessed, and these patients received antibiotics for 4 days, a combination of antibiotics. So the patients who received one antibiotic, they found that it took 3 months for the native microbiome to grow back. And those who received 4 antibiotics of different classes, it took even at 6 months, the native microbiome had not come back. So basically, perturbations could be based on the nature of the therapy that is given. And the second thing that would be important, I think, would be the native microbiome, the diversity of the microbiome that is more important in these cases. Possibly, as we see in young children, if you give antibiotics at a very early stage of life, they tend to be more predisposed to multiple diseases. And the microbiome of a young child is very susceptible to change. So infant can get the microbiome from his mother based on the mode of delivery. He can have a vaginal microbiome, or a breastfed infant can have a different microbiome. So it is very susceptible to change because there is not much of variance in the initial stages of life. In C. difficile colitis, similarly, you have the patient has already been subjected to lot of antibiotics and his native microbiome is gone. So now, when you give him FMT, so this FMT works within 1 or 2 or 3 days. So you see clinical improvement within 3 days because there is the diversity is lost. So he's more susceptible to change. Whereas in a patient with IBD who has been having long-standing established microbiome, which is dysbiotic, a single FMT might not always work. So you, as Dr. Ajit has been following, I think you need to give them multiple sessions of FMT to bring about a sustainable change, which might lead to more clinically relevant outcomes.
Do we have Dr. Pradeep Bhaumik here?
Yeah, Dr. Rupa, do you think that fecal transplant will work best after preparation for colonoscopy? If you do preparation for colonoscopy, as in colonoscopy, and after that, if you do fecal transplant, will it work best or not? What is your opinion?
I think this is a good question, but actually we do prepare because we are doing a colonoscopy and spraying from the terminal ileum and then coming out by spraying all across. Whether that increases adherence inside, we don't know. The other is because sometimes we are giving through the, studies have shown that you can give it through the nasal route also, or the, the oral feeding into the jejunum. In that case, there is no colonoscopic preparation per se, so that also does work. So fecal transplant, there are a lot of questions to be answered, but initial results are good. And I think as we know more about microbiome, we have more definite things what to do. Even fecal transplant may become more personalized. Which type of flora we will give, we can just go on to that.
Thank you, Rupa. I am extremely thankful to Dr. Ajit, Dr. Rupa, and all the expert panel members for having us taken through the journey of fecal microbiome and fecal transplantation. Because of the shortage of the time, we may have to unfortunately end this brilliant session, and we finally come back to the final session of the day, that is non-surgical management of the weight loss strategies. The speaker for today is Professor Barham Abudai, who is the world authority in these type of concepts of non-surgical management. And to moderate the session, we have a brilliant, most astute clinician and a mature person, Dr. Anil Anand. I have the privilege of working with him and being a student at the formative days in All India Institute of Medical Sciences. The floor is with you, Professor Anand.
Thank you, Professor. At the time when we are beginning this session, we should have actually ended. But as most people in India are picking up their dinner plate, we are going to talk about the weight loss strategies. And the best weight loss strategy would be to attend the session and not have the dinner. This session will consist of one guest lecture and a panel discussion. And the person to deliver this talk on complex subject of non-surgical weight loss strategy is none other than Professor Bahram Abudai from Mayo Clinic, Rochester. Bahram is a professor of medicine, consultant in gastroenterology, hepatology, and therapeutic endoscopy there. He is also the director of advanced endoscopy with special interest in bariatric and metabolic endoscopy. Before I hand over the mic to him, I'll quickly introduce my panel, which is going to be there. The panel discussion will be spearheaded by our senior most hepatologist and the expert in therapeutic endoscopy, the teacher of teachers, our Bhishma Pitama, Professor Jang Dilawri from Chandigarh. Then we have senior consultant in gastroenterology and the most distinguished academician from Vishakhapatnam, Dr. Shiva Prasad. We have Dr. Kapil Jamwal, the consultant gastroenterologist and a famous endoscopist from Artemis Hospital, Gurugram, NCR. We have Dr. Saransh Jain, very well-known and famous gastroenterologist from Bhopal, MP. And I don't see Kumar Abhishek. Is he here?
I think he's possibly not there. Yes.
Okay, we'll let it be. So I now request Professor Baram to deliver his talk, and then we will have a final discussion subsequently.
Thank you, dear colleagues. Thank you, Dr. Anand, for the nice, kind introduction. Good evening to friends and colleagues in India. It's unfortunate that we cannot be together in person, but hopefully with getting handle on this pandemic, things will change and we'll be able to intermingle and network together. I will share my screen. So today we're going to be talking about non-surgical weight loss strategy. This is a topic close and dear to my heart, and I think the future is going to migrate where we're going to utilize the power of the GI tract for treatment of obesity and metabolic disease. These are my disclosures. I do work with multiple companies who are developing therapeutics in this space. So obesity is not really a life choice. Obesity is truly a pathological disease with clear genetic, epigenetic, and environmental and psychosocial factors. These factors coalesce to have the phenotype of obesity, which have multiple psychologic and medical implications to health. As you could see, the burden of obesity lies on a spectrum, and the relative mortality that could be attributed to obesity start increasing at the overweight range and exponentially start going up even with mild to moderate forms of the disease. The GI tract is really front and central in this pathophysiology. The GI tract is the orchestra maestro, basically, that organizes the response to a meal and interact closely with visceral and adipose tissue to coalesce this phenomena of metabolic syndrome due to chronic inflammation. So really the GI center, the GI is a key both in the pathophysiology of the disease and as a therapeutic target for this disease. It's very important to highlight, especially for a lecture with our colleagues in India, that the burden of the disease is different in countries like India and China. If you look at the same graph that I showed you from a white Caucasian study in the New England Journal of Medicine that looked at the burden of the disease at different BMIs, you could see that this graph is shifted in Southeast Asian and Chinese population because of this concept of TOFI, or thin outside, fat inside. So if you look at this PET scan from individuals matched by age, gender, and BMI, you could see that in one individual, there's a significant burden of visceral fat, about 6 liters. And in the same individual with the same body mass index, there's a much lower amount of visceral fat. And again, highlighting that the disease is excess adiposity, not necessarily tied to BMI, and the interaction between the gastrointestinal tract and visceral adiposity is very important in the pathophysiology of this disease. So again, when we talk about non-surgical management option for obesity and metabolic disease, it's very important to highlight this ROSE prevention paradox that applies to any chronic disease. So we need to have a global strategy, which is policy-based strategy that shifts the bell curves of the disease toward the left. But that also needs to be married with a strategy to treat sick individuals, because we'll have sick population and sick individuals, and the strategy to treat the sick individuals will have to shift the burden of the disease within the bell curves, not just the bell curves. And that's where all the therapeutics that we're going to be discussing will fall into that. So the major therapeutic targets are to improve insulin resistance, decrease excess visceral adiposity, decrease inflammation, and restoring mitochondrial health and the process of autophagy. And we will get there with weight-dependent and weight-independent pathways. So if you look at a 5% total body weight loss, you could expect improvement in cardiovascular risk. However, the true new goal for weight loss is more than 10%, because that's associated with diabetes improvement, cardiovascular outcomes, and also resolution of NASH and liver fibrosis. So if you look again, here is, let's take NASH as an example of a prevalent metabolic disorder associated with insulin resistance. And you could see if you put NASH on this scale and you put weight loss at 10%, you could see that weight loss at 10% is associated with significant fibrosis improvement and NASH resolution compared to multiple pharmacological agents, whether targeted to the liver or elsewhere. So that's, therefore, targeting this 10% weight loss is critical in this disease process. The problem that we're having is only the minority of patients are able to reach this 10% total body weight loss with non-interventional strategies focusing on lifestyle intervention and pharmacotherapies. So therefore, we really need a spectrum of care where we integrate on the backbone of a comprehensive lifestyle modification program, medications, endoscopic and surgical treatment in order to treat this sick population and sick individuals with obesity. So let's talk about lifestyle modification, diet, and medications. Then we're gonna go on to talk on the endoscopic treatments. There is some misconception about lifestyle intervention. People think it does not work. Actually, it does work, and it's really good for maintaining weight loss. It's not as significant of a weight loss as you would see with a device or a procedure or a surgery. However, it should be the backbone of any management strategy. This is the look-ahead trial that randomized about 5,000 individuals with body mass index above 25 and type 2 diabetes to either intense lifestyle intervention versus regular standard of care for their diabetes. So if you look at the results, you could see that there is, with an intense lifestyle program, there is a significant portion, about 30% of the population, that did lose more than 10%. So the concept of intense lifestyle modification does not lead to weight loss is not true, actually. It's not the same weight loss as you would see with surgery, but it's medically meaningful weight loss. The other concept is, what's the long-term effect? You could see that a long-term effect, if you continue this intense lifestyle modification, at 8 years, the individuals participating in the trial still seeing about 4.7% total body weight loss compared to 2.1% in the standard of care arm. What's also important to see that not everybody responds the same. You could see that there is about a quarter of this group that lost more than 10% total body weight loss at 8 years, indicating that some individuals will respond better than others for these lifestyle interventions, and they should be offered as a baseline for all therapeutic options. Now, when we look about lifestyle intervention, is it diet, is it exercise, is it both? This is a meta-analysis looking at diet and exercise versus diet alone, and you could see that it's mixed results. There's a lot of overlap around the center, favoring diet and exercise versus diet alone. When you flip the story and look at diet and exercise versus exercise alone, you could see that the story is different. All studies favor diet and exercise versus exercise alone. So if you want to focus on one area, you focus on caloric restriction and diet. Exercise is a good benefit, but diet is the primary component of this intervention. Now we're going to go up the ladder here and talk about medications. Then we'll talk about endoscopic therapies. We will not have time today to discuss bariatric surgery. So first, in a medical management for obesity and metabolic disease, it's important to review the patient's medication risk, because some medications could be unfavorable or result in weight regain. And these are a list of common medications that are associated with weight regain. So if there's an opportunity to switch the patient safely to a weight neutral or weight advantageous alternative, that would be a good strategy. Again, it's important also when you're managing type 2 diabetes to build on a backbone of metformin. Metformin have weight favorable properties. And if you're looking at your next choices for that, it's important to prioritize GLP agonist and SGL2 rather than the metabolically unfavorable or weight unfavorable options such as TZDs and sulfonylureas. Then we're going to talk about, after you review your medications, you optimize weight favorable medication, is talking about direct anti-obesity medications. In the United States, we have 4 currently on the market: orlistat, phentermine, topiramate, naltrexone, bupropion, and liraglutide. And leucovorin was pulled off the market because of the slightly increased risk of cancer. Orlistat is a pancreatic lipase inhibitor. Its most common adverse event is GI side effects like fecal urgency and soiling. If you look at the long-term results with this agent, this is a study that extended to 208 weeks. You could see compared to placebo, it results in about 5.8 kilograms weight loss compared to 3 kilogram weight loss. Now, not earth-shattering weight loss results, but significant nonetheless over an extended period of time. Second agent is this phentermine topiramate. It's phentermine. It's a sympathomimetic drug that works on appetite, and topiramate is a GABAergic drug that works on satiety. This is the dose escalation with this agent. Again, if there's no weight loss at 3 months or defined as 3%, you discontinue the agent because it's not likely it's going to work. The most important adverse event is it's teratogenic. Therefore, there's increased risk of oral cleft palate formation, and it's contraindicated in the first trimester of pregnancy. It's probably the most effective of all the medications that we are having, and about 70% of the population subjected in this randomized trial to this agent lost more than 5% total body weight loss, and 48% lost more than 10% total body weight loss. Naltrexone and bupropion, naltrexone is an opiate receptor antagonist, and bupropion is dopamine reuptake inhibitors. Again, there is a dose escalation. Same principle. If the patient did not lose more than 5% total body weight loss in the first 3 months, discontinue the agent because it's not likely to be effective. There is the associated risk, adverse risk profile with this medication. Generally, it's a very well tolerated medication and probably the safest of all the medications that I just presented. Results is about 6.5% total body weight loss compared to 1.9 in the placebo arm that tends to be maintained in responders over 56 weeks. Liraglutide is a glucagon-like protein receptor agonist. It suppresses appetite and it delays gastric emptying. There's a dose escalation with the most effective dose is 3 milligram subcutaneous daily dose. Discontinue if there's no response in the first 3 months, and adverse events are listed, but the one to pay attention for is pancreatitis. These are the warning and contraindication of the drug. This is a complicated multi-field trial that compared liraglutide at different doses to placebo and orlistat. And you could see that the liraglutide is more effective than placebo and more effective than orlistat, with resulting in about 10 kilograms weight loss at 52 weeks with the highest dose. And this response is maintained up to 104 weeks in responders. So overall, if you look at the placebo subtracted changes from baseline for these drugs, you could see that they result in about 3 to 9% total body weight loss. Collectively, they do not bridge this threshold of 10% total body weight loss. Now, if we go a step beyond medications and go to endoscopic therapy, the hope here is we could bridge or exceed this threshold of 10% total body weight loss in the majority of the population. The reason we need devices and techniques that are minimally invasive and accepted by patients is that most of obesity and metabolic disease goes unchecked. In the United States, we have 19 million individuals who would qualify for bariatric surgery, but only 1% of these individuals opt to get a surgery. Similar with medication, we have about 88.6 million who would qualify for a medication, but medications have their limitations, and about less than 1% of patients who qualify for these medications get it or refill it. Therefore, 99% of the disease burden is unmet. Therefore, the hope is similar to the field of cardiology, where there was open heart surgery and there's medical therapy. The field of minimally invasive cardiology bridged this gap. We're hoping that the field of endoscopy bridged this gap between medical and surgical management. So to talk about some of these devices, they come in different flavors. You have the space-occupying devices that come in the form of intragastric balloon. There is a device called the transpyloric shuttle that intermittently causes transpyloric obstruction, delaying gastric emptying, and then in the fasting state, it goes back to the stomach. And then there is a device that we're currently investigating with our colleague in AIG called the full sense device. This full sense device puts pressure in the afferent vagal nerve endings that in the cardia, causing the sensation of fullness, independent of calories. So you do not need to eat in order to trigger the mechanism of action of this device. So collectively, these are the multiple randomized controlled trials that are published in the United States, comparing the efficacy of space-occupying devices compared to a lifestyle or sham arm. You could see now collectively these devices do reach the 10% total body weight loss threshold. Now, the biggest buzz and the biggest hope in this field is using gastric remodeling, because gastric remodeling is a concept that appeals for patients because they're keeping their stomach, they're having an effective and well-tolerated procedure that has very low risks, similar to any endoscopy, in order to remodel the stomach for weight benefit. This is the endoscopic sleeve gastroplasty that takes the stomach, reduces its longitudinal and axial length and diameter to create a banana-sized stomach with decreased accommodation and delayed gastric emptying. Now, the first reports of this procedure was from the Mayo Clinic in 2013, but since then, this procedure has been globally grown with now more than 25,000 procedures performed worldwide. This is the concept. We live now in the era where we could introduce with high fidelity, full thickness sutures to reduce the size of the stomach through the mouth. This is the first sequence of the procedure that I'm showing here, and you march the suturing line in order to create the effect that's desired. So newer procedures are coming that are offering more automation, so it does not require too much skill of the operator. For example, the one on the the one on the left, sorry, is an automated suturing device that all you need is you need to put it in the stomach, then you press a button, and then it automatically suture. And the other one on the other side is different plications that reduce the stomach by 6 centimeters each. And you do an organized sequential pattern where you reduce the stomach similar to an endoscopic sleeve gastroplasty, both along the longitudinal and axial length, to decrease the accommodation and also to decrease to alter the emptying of the stomach for weight benefit. Both procedures, the post 2.0 procedure is really technically easy procedure that takes about 25 minutes to perform. Therefore, these procedures will likely revolutionize the therapeutic offering for these patients. Again, this is the early report. This was the multi-center study between Spain and Mayo Clinic in 40 patients. And now the FDA expanded the study to enroll 40 patients in the US, and more results will come. But collectively, if you look at gastric remodeling, this is going back to the endoscopic sleeve gastroplasty, you could see now that we're with confidence, we're producing about 17% total body weight loss at 1 year after these procedures, with a very low incidence of serious adverse events at 2%. Now, this is from Cornell that followed about 200 patients to 5 years. You could see now, you give the patient a gastric remodeling procedure, and you give them a good behavioral lifestyle program, and the weight loss will be durable. This is weight loss followed to 5 years, showing that the weight loss is at about 15%, extending to about 5 years after the endoscopic sleeve gastroplasty. The other gastric intervention here is aspiration therapy, which is a modified PEG tube that allows the patient to aspirate a portion of the ingested meals after each meal. This tube is, technology has been evaluated in a randomized open label trial, and you could see with this technique as well, you're reaching this 15% total body weight loss compared to about 3 to 4% in the lifestyle control. So if we put back the spectrum of care, this is what patients care about. Patients do not care about average. If we say that 10% total body weight loss is the minimum threshold to improve most of the metabolic burden of disease like NASH, you could see here you start from lifestyle intervention to different medication to bariatric surgery. This is the percent responders at 10%. You could see that endoscopic bariatric treatment fills this gap very nicely. And now they're offering the majority of patients the opportunity to reach this 10% total body weight loss at 1 year. Now we're going to shift gears, talk here and talk a little bit about these weight-independent pathways that are favorable for metabolic health. And the duodenum here really is a front and central in this, because the duodenum offer a very rich ecosystem that orchestrates a very robust metabolic response to ingested meal. The data here is significant and good. I won't have time to go over all this data, but I'm gonna ask you to, in your mind, imagine 2 states of duodenum. There is an insulin-resistant duodenum associated with metabolic disease such as NASH, PCOS, and type 2 diabetes. And there is a metabolically healthy duodenum that interacts with the liver, central nervous system, adipose tissue, pancreas, and peripheral muscle. And the goal here is to use this orchestrator of metabolic response and reverse the course from a metabolically diseased insulin-resistant duodenum to a metabolically healthy duodenum. What's the hallmark of a diseased duodenum? A hallmark of a diseased duodenum is you have a decrease in the stem cell niche of both Paneth cells and stem cells in the crypts of the duodenum. You have increased proliferation of enterocytes that's associated with metabolic disease. Also, you have leaky gut with decreased diversity of the microbiome and decreased mucosal layer. And you could see a phenomena where this leaky gut and decreased diversity of the microbiome or the dysbiosis resulting in translocation of mediator of inflammation to the portal circulation and to the liver, causing the common diseases that we are aware of, like NASH and inflammation of visceral fat. So the question is, could we take this insulin-resistant pro-inflammatory duodenum and change it to an insulin-sensitive anti-inflammatory duodenum using different technologies? The first technology that we'll talk about in this regard is this bypass liner that bypasses the 65 centimeters of the duodenum and the jejunum. The one on top is been in clinical trials in the US and currently is ongoing. It's called the endobarrier. The one below is a company called Metamodics that have atraumatic anchoring of this device and is currently in clinical trials with AIG in India. The biggest hope, though, is similar to Barrett's esophagus. We ablate Barrett's esophagus in the, and it does not come back as columnar, it comes back as healthy squamous epithelium. So could we use technology to ablate this diseased duodenum and reset the metabolic clock into an insulin-sensitive duodenum. There's multiple companies. One is using a laser to do this. Another is using heated water to do this. And the newest kid of the block is using non-thermal ablation through the process of electroporation to do that. The company who did most of the work in this field is called Fractal, that use a circulated hot water in order to ablate the duodenum. So they use this balloon to cause a 360 lift, starting distal to the papilla, and then once you do the lift, you circulate the heated water in order to ablate a zone of about 10 centimeters from the second duodenum to about the ligament of Treitz. This was published in Gut just this year, that looked at prospectively about a cohort that underwent the duodenal ablation with a single session. You could see that A1C have a significant drop up to 12 months with very limited weight loss. So now we're talking into a zone where you could harbor the metabolic benefit of the duodenum in order to treat diseases like type 2 diabetes and fatty liver disease. Again, I told you about this technology of electroporation. The beauty of electroporation is there's no thermal injury. The cells of the duodenum could be ablated through the process of apoptosis and programmed cell death. So you could ablate a high surface area of the duodenum just by introducing a high pulsed, high voltage burst of electricity in order to ablate the duodenum using electroporation rather than heat. The last technology that I will talk about in this space is a technology called endoscopic anastomosis. And with that it's more capitalizes on a change in bile acid circulation. This technology in its current form requires two operators. One is intubating from the lower GI tract into the terminal ileum. And the first operator is performing the endoscopy from the upper GI tract into the jejunum. Once these two magnets mate, they will form a side-to-side jejunal-ileal bypass with the idea that bile will bypass the majority of the small intestines, be dumped early into the ileum, creating an incretin response that is favorable for metabolic health. So what's the future? We talked a lot. I'm sorry, because of the limitation of time, I could not discuss any of these in details, but the future is as follows. The future is we will have repeatable EBTs. That means you could see that you could do an endoscopic sleeve or put a balloon and then repeat it or retighten it. We could do combinable EBTs where you put a gastric device or a gastric procedure and add a small intestinal pathway for enhanced metabolic health. We could do sequential endoscopic bariatric treatment, and then we could do enhanced. So I showed you that most of the interventions of endoscopy results in weight loss of more than 10%. So could we use this weight loss that we obtained with these devices and add a medication that will maintain the weight loss for the longer period of time in order to treat the disease of obesity and metabolic disease with success and with patient acceptability. And the future is personalized procedural choices based on understanding of the physiology. So in conclusion, we need more therapeutic options to tackle obesity and metabolic disease. The GI tract is front and central in weight and metabolic regulation. Endoscopic bariatric and metabolic therapies will play a major role in the management of obesity and its metabolic consequences. And with that, I would conclude with a quote from the founder of Mayo Clinic, or one of the founders of Mayo Clinic, Dr. William J. Mayo. I look through a half-open door into the future, full of interest, intriguing beyond my powers to describe. This future is bright for metabolic health, giving the powers of the GI tract. Thank you.
Thank you, Madam. That was an excellent and a very comprehensive talk. While we wait for the audience questions, can I start the ball rolling? And my first question, I think, is for Shiva. Professor Abudaya has very elegantly shown the value of lifestyle modification. And for having a lasting effect on weight loss, I think behavioral change would be required. How can one achieve that, and how effective is that?
Yes. So we showed from the look ahead trial that behavioral intervention could be effective and should be the backbone of any strategy, because I mean they're very safe. So in a subset of patients subjected to an intense behavioral intervention, with intense I mean multiple visits a month for the first year, then start staggering them in order to tackle different areas of behavioral or cognitive behavioral therapies. It could be effective. In a subset of population, it could be as effective as bariatric surgery. But in the majority, it won't be as effective as bariatric surgery, but it would be the backbone to add it to the different interventions, whether pharmacotherapies, bariatric endoscopy, or surgery, as to augment and enhance the maintenance of the weight loss obtained by these interventions.
Shiva, do we have similar things available in India? What is your take on that?
No, I think it has been highlighted that the limitations of diet, I mean lifestyle and behavioral therapy, as far as clinical results in the population is concerned. Number one, we know that doesn't apply to only a subset of people will respond. Number two, it's a sustainability. You're talking of lifestyle. You're not talking of 6 months or 1 year. You're talking for the rest of the patient's life. Is it sustainable? And thirdly, whatever, even in the look ahead study, even though they achieved the goals of, weight loss and metabolic markers, it's even over the course of 9 years, they could not achieve the goals of cardiovascular outcomes. And in fact, the study was stopped due to futility. So that is another level altogether, that you're achieving all these goals, but are you really achieving the cardiovascular improvement that you're looking for? So it's really difficult. The second point is, I would like to say that, as has been highlighted, BMI is okay for about 35. You just want to monitor weight loss, weight gain. But I think in the vast majority of patients in the 24 to 30 BMIs, really speaking, we need something better than weight. We need some metabolic marker that we can say reflects metabolic health better than weight. And as far as diet is concerned, I think a big problem is most physicians just think caloric restriction is the answer, but we know that it's much, much more complicated than that. And probably our knowledge today is not sufficient to say what is the right diet for which kind of person. Do we need to, again, tailor the diet to the individuals? You're talking of carbs. It's not just the composition of diet, the timing of the diet, whether it's, what type of carbs, what quantity of carbs, which sugars are there, which are not, and saturated fat, unsaturated fat, omega-3, omega-6, the list goes on. And you're not even yet reached the problem about how the microbiome influences all this.
Okay, I'd like to limit the answer because the time is short with us. Kapil, can I ask you a question? I feel that food stimulates the same pleasure centers that the alcohol stimulates. And eating more and more calories is possibly similar to alcohol addiction. Do we have some de-addiction programs or drugs that can be used towards that? How effective are those?
So there has been data initially that there have been neurological transmitters which are involved in this one, eating disorders. Like there have been like the drugs which were initially designed like opioids, then some dopaminergic pathways as well as GABA was involved in. This was the initial research in 90s. But it showed, but there has been not a big correlation between this and the eating disorders, and as well as, so what is now correlated that these eating disorders are associated with substance abuse disorders. Like they have alcohol abuse along with other substances like drugs are very common in patients who are obese or who have eating disorders. This may be because of their lifestyle, the stress, or the other things which are associated with it. But so when we, in our center, or in most of the big centers, when they subject these patients to bariatric or such programs, so a psychologist or a psychotherapist is always involved before a patient is subjected to procedure, because there can be other therapy which will be required. But normally the drugs which Dr. Burham has already covered, these are the drugs which are used in treatment of these disorders, and not any particular psychotic or psychiatric drugs are being used.
Burham, I'd like to ask you one question which was carried over from the previous session. Rupa had asked me, would you like to use fecal microbiota transplantation for treatment of obesity? So what is your take on that?
my take is I think it's quite premature for this indication. Currently, what we need to use for obesity is simple. It's caloric restriction without having the body fight the caloric restriction. So now and this has been demonstrated elegantly in a New England Journal of Medicine, where they took individuals, subject them to a very low caloric diet. They lost significant weight, but their body counter-regulatory mechanism kicked in, so these people were feeling hungry. Their ghrelin levels were increasing. So the key here is we have to have a paradigm shift. We have to give patients medications or procedures that impact satiety and satiation, and then subject them to a low caloric diet. I don't care what's in the diet per se, it's low caloric diet. And this would lead to all the metabolic benefit that you want to see. So the paradigm is, which I will echo what Dr. Prasad just said, is subjecting somebody to behavioral therapy when they cannot lose weight because their body is fighting them is you don't have an engaged patient. Take that patient and make them lose 15, 20% of their body weight, and now give them the intensive lifestyle interventions and behavioral interventions and medications. Their chances of doing well is much higher because you have an engaged patient that now their task is to maintain the weight rather than to lose it, which is it's a paradigm shift in this field that goes against this staggered approach by saying we need to be aggressive with putting the disease in remission, then using all the agents on our disposal in order to maintain that remission. And that's the key here, especially for a disease like fatty liver disease.
Kapil mentioned about the substance abuse, and it is well known that people who lose weight after bariatric surgery, they switch to different substance abuses. Do you observe the same thing with the bariatric endoscopy?
So it's again, the field of bariatric endoscopy has not been as mature as bariatric surgery. So we still need time to look at some of these issues. But so far we have not observed any of this. And hypothetically, we would not observe it because you're maintaining the gastrointestinal tract and you're not altering these interactions too much. I mean, it's anatomy preserving. That's the key here. So hypothetically, we're not going to see the same things, but and the important thing is some people get these addictions because they were addicted to food without enough counseling before bariatric surgery, and now you give them a permanent option and they cannot eat again because physically they cannot take the same amount of food, so they go to substance as an alternative, substance abuse as an alternative. With bariatric endoscopy, reversal of the intervention is always possible. So if that is going to be the case and you see somebody is struggling because they cannot give up their old addictions, you just reverse their procedure and switch them to something different.
Okay. Sir, Professor Dilavri sir, which endoscopic therapy focused on stomach would you prefer in your patients? And what happens if the patient has NASH or cirrhosis associated with it?
Thank you. First of all, I like to highlight is that the lifestyle modification, the diet and exercise involves a motivated team and motivated patient. And unless you have these two things, things would not work. The drugs, I'm not in favor of drugs. The next step is the endoscopic intervention. I think balloon are the initial step to use, and that helps in a lot of patients. And if that fails, then my next step would be the endoscopic bariatric surgery, and that will be endoscopic sleeve gastroplasty. That would be my approach. But lifestyle modification, diet and exercise will form the basis of everything. That has to be maintained all the time. But the patient has to be motivated, and the team which initiate that has to be motivated as well. Then the endoscopic bariatric surgery will come the next step.
Would presence of NASH or cirrhosis make a difference in your approach?
Well, it will be difficult to have a patient with cirrhosis and portal hypertension to do an endoscopic procedure. You can do the balloon, that will be safe. But it will be almost impossible, I think. I'll ask Professor Abude whether in portal hypertension, whether you can do endoscopic sleeve gastroplasty. I doubt it it would be very dangerous to do that.
Baram, what is your experience on this?
Well, first I will echo Professor Delawari's excellent comments. He's right on the spot. Again, we have to get and engage patients. And patients do not get engaged unless they lose the weight, and then they're much more engaged to maintain it afterwards. So that's completely right. Now, for me, we still do not know the safety of either balloon or endoscopic sleeve gastroplasty with portal hypertension. We did early studies that looked at pre-transplant, pre-liver transplant individuals that needed to lose weight, and it's been safe to do balloon. We have not evaluated the same thing with the endoscopic sleeve gastroplasty. So right now the jury is with compensated cirrhosis, probably both interventions are fine. With decompensated cirrhosis and severe portal hypertensive gastropathy or varices, then in my opinion we still do not have enough data to say if either interventions are safe. The key, however, is the following. We have a tool that could cure NASH. Much better than any drug is capable. And we demonstrated this clearly in a study that we published in CGH, that the balloon could resolve NASH to an NAS less than 2 with regression of fibrosis in the majority of patients. If you use it, then use it as a remission agent of the disease, then have everything else to maintain the weight, like the GLP agonist or the lifestyle intervention. So the paradigm shift should be that we should not reach to the procedure when patients are failing. We should be reaching the procedure when the patients are motivated and get them on the pathway of remission and then maintain the effect later. So that's probably the biggest take-home point I would go with, is this is a disease that has no cure. We could impact its course significantly, and we should use all the tools at our disposal to do that.
But I want to ask her, have you got experience with doing sleeve gastroplasty? It compensated cirrhosis.
Yes.
I think that is even that is dangerous.
In compensated cirrhosis, I've done it, and I've done it safely. And to me, actually, which is kind of a little bit kind of a not very intuitive point, but if you ask me personally, which procedure I think safer, is it the balloon or endoscopic sleeve gastroplasty? In my hand, which I've done more than 2,000 procedures of this nature, I would tell you, for my patient, I think endoscopic sleeve is safer because there's no implantable device. And it's based on the evidence that we have, the risk of intolerance and intractable vomiting and the stuff are not seen as you see with the balloons. So to me, I think trials need to be done. But as we stand, I think the endoscopic sleeve gastroplasty is safe probably in compensated cirrhotics with mild portal hypertensive gastropathy.
Okay, one question from Saransh.
Yeah, okay.
So, Saransh, what do you think about the duodenum-focused endoscopic therapies? Are there specific subset of people where they should be tried, or they are generally more effective than stomach-based procedures?
So, as per GI tract, stomach deals with weight control, and duodenum is the center of metabolic control. So when we are dealing with duodenal therapies, we are looking at glycemic health. We are having improvement, weight independent improvement in glycemic control. So whether you ablate the duodenum, whether you bypass the duodenum, whether you coat it with a new drug which has come, you're basically trying to control the metabolic aspects of obesity rather than focusing on weight. Weight is majorly controlled by the gastric therapies. Therefore, as Professor Abudaya rightly said, the future is to combine the therapies. Asking combination of gastric and duodenal therapies for both weight as well as metabolic control in obese patients.
Yes, Shiva, you wanted to say something?
One question for Dr. Baram. How important is assessment of pre-procedure gastric emptying in terms of selecting patients for the procedure, and also post-procedure, the results that are likely to come based on gastric emptying studies?
Excellent question. I think that's assessing physiology as predictors of which procedure for what patient for tolerance and efficacy is going to be the future. Gastric emptying is going to be important, and I'll give you an example. we know that the majority of the effect of the intragastric balloon is based on a delay in gastric emptying. I mean, that's clearly established. And we know that a lot of the intolerance of the gastric balloon, that's why 20% do not tolerate it or 10% do not tolerate it, is the results that you get somebody who has a delayed gastric emptying at baseline, the balloon, and now you put them into a phenomenon where the stomach is not working at all and they cannot tolerate the balloon and you have to remove it. Therefore, we demonstrated in a recent publication that if you use gastric emptying to select your patients for balloon, the safety and tolerance is significantly enhanced because you're going to eliminate those with delayed gastric emptying at baseline from getting the intervention. But also you could use it for evaluating the response. The majority of people, you put a gastric balloon in their stomach and you measure their gastric emptying at 3 months, show a significant delay. They go from a T50 of about 80 to a T50 of about 160. And these are the people who lose significant weight. There's a subset of about 20% where you put the balloon in them and their T50 does not change. And these are the people that tells you, I cannot feel that there's a balloon in there. I'm hungry all the time. And for these, it's futile. You know, I tell them, we do not need to keep the balloon for 6 months because you're not going to respond. So I just remove the balloon and give them something different. So there's a lot of value for using this physiology to understand predictors for safety and tolerance, but also efficacy and what adjacent or adjunct intervention that you would offer the patient.
Do we have the same data for ESG?
Yeah, may I add on that? Sorry, may I add on that point?
Yes,
ESG delays the gastric emptying, whereas post-2 increases the gastric emptying. So if you have a already delayed gastric emptying, you would like to offer him post-2. And if you have a faster gastric emptying person, you would offer him an endoscopic sleeve. So gastric emptying also helps us choose between the endoscopic options that we would like to make for the patient. Maybe Professor there would help.
Absolutely, and actually this is exactly right, and that's why we're part of the post-2 study that imbricates and tubularized the stomach. Is we looked at that question, and you're right, it's endoscopic sleeve has multifactorial effect on accommodation and emptying, but it delays gastric emptying and decreases the accommodation. The post-2, it seems to speed the gastric emptying in a subset of patients and delays it in the others, and also affect accommodation. So yes, we're heading to that era where we're gonna start selecting the procedure based on the patient's physiology. And now luckily that we have the gastric emptying that's based on a breath test. That means you do not need to expose patient to radioactive isotopes. You could do that test either at home or in the office where the patient is blowing into tubes and you have a nice figure of what's their emptying in order to select your procedure. So personalized choices are coming in this field for sure.
Thank you very much. I'm getting a signal from Professor Arora that a lot of time has passed and I think we should close. I'd like to thank our speaker, the guest speaker, for an excellent talk. And I'd also like to thank my panelists for giving wonderful answers, clarifying all the doubts that people had. And thank you very much. I hand over back to Professor Arora.
Thank you.
Thank you, Professor Anand, for excellent exposition of and moderation of the session. And I am extremely thankful and grateful to Professor Abu for having spared his valuable time and in such short time to give you such lucid description of weight loss strategy. I don't think anybody could have done a better job. Now, with permission of Dr. Anand, can I just ask one question to Dr. Abu?
Okay, sure.
Yeah, you see, everything Abu has to go via either through the stomach or through the duodenum. Everything has to ultimately go to hypothalamus for inducing satiety. So why interfere mechanically, chemically, and biochemically in these areas? Why not look for something like receptor leptin resistance? Why not undo that? People can enjoy their life. Stomach has multiple functions of acid production, decreasing the inactivating the incoming swallowed bacteria. So why not act at the level of hypothalamus and go away from stomach and duodenum? You don't need anything. Let anybody eat anything.
Very good question. I wish it's that easy because we would have figured it out by now, and people have tried to look at directed therapies to the hypothalamus and did not succeed because of the simple answer. Over the course of evolution, we evolved against starvation, not against excess calories. And the pathways that protect against these are multitude. and compensatory. That means you could block every receptor for ghrelin or leptin, and you will have 10 others that will pick up the slack in order to prevent from starvation. However, so that therefore now we're going from a receptor-based therapy to an organ system-based therapy. The coordinator of this response is the GI tract. That's why the most successful treatments, whether surgical or endoscopic, works in the GI tract, because the GI tract is the maestro that organizes this orchestra that includes the hypothalamus and the brainstem and the pancreas and the liver. Therefore, if I'm a betting man, I will always bet on the GI tract, and I'm not conflicted in that answer because I'm a gastroenterologist. I think that's reality.
Okay, thank you so much. With that, we come to the end of the formal presentation from today. But as has been the customary presentation in this meeting, we try to summarize what we have learned throughout the day. So may I request my dear colleague, Dr. Ashish, to give a summary of the day for the people who have just joined late and have a recap of all those who have attended the seminar. Dr. Ashish, please.
Thank you, Dr. Arora. So we had excellent 5 lectures. We started with Dr. Usha Datta, who talked about functional bowel disease. So she covered mainly functional dyspepsia, and she told that the prevalence is around 30%. And of this 30%, 70% is mainly functional, and rest is organic. So she told about symptoms like pain, burning, fullness, and satiety. And she told about paradigm shift in our understanding about the functional dyspepsia, especially when it was initially thought that the site of the disease was stomach, but now it is thought that it is mainly duodenum. Initially, it was thought that muscles are involved, but now mainly causing dysmotility. But now she told that mucosa and especially leaky gut is involved. Initially, it was thought that there were no bugs involved, but now it is microbiota driven. Initially, CNS was in thought, now it was enteric nervous system. And the therapy has also changed from symptom-based therapy to a target-based therapy. And now it is more of a personalized therapy, which is coming. She told about H. pylori infection and the benefits of treating H. pylori also improves functional dyspepsia. And she talked about personalized medicine, like if there's a component of dysmotility, then prokinetics will help. If H. pylori is there, then anti-H. pylori therapy. If there's duodenal inflammation, then montelukast will help. And similarly, where tricyclic antidepressant, if there's more of psychiatric morbidities, and if there's more of acid component, then PPIs will help. The second talk was by Dr. Vineet Ahuja, who told us about 5 new concepts in inflammatory bowel disease, mainly about vedolizumab, ustekinumab, tofacitinib, and he also talked about ileocecal Crohn's disease and COVID-related and inflammatory bowel disease. So initially, first he talked about the vedolizumab, which is a Varicity trial, which is a lymphocyte trafficking inhibitor, and he showed that in the study which was published last year only, vedolizumab was superior to adalimumab. And he told where's the role of vedolizumab, which is mainly in ulcerative colitis, especially steroid-dependent induction, and also steroid-dependence maintenance, but not for acute severe ulcerative colitis. And also it could be used for B1 inflammatory Crohn's disease. He then covered about ustekinumab, and he told about that it is mainly it is a second line agent. Infliximab is still the first line agent, but it can be used as the second line agent. Then oral small molecules like tofacitinib he covered, which is very good, but there are certain side effects to that, and it is also used as second line agent. Then he talked about ileocecal resection versus infliximab, and he compared the long-term results, especially 5-year result. And he showed that if surgery is given early on, then these patients have better response. They do not require a second surgery, and they don't even require a second therapy. While if infliximab is given as the first therapy, then half of these patients require surgery within next 5 years. He talked about inflammatory bowel disease in this COVID era and about rapidly changing opinion. And now inflammatory bowel disease in this COVID era is treated almost similarly as before. So we can give IV steroid, and if surgery is required, it should not be withheld, and thromboprophylaxis and biologicals all can be given. And next talk was by Dr. Govind Makaria, who talked about recent concept of celiac disease. And his initial presentation was about epidemiology, and he had published a good meta-analysis, and which told that seroprevalence of celiac disease about 1.37%, which is quite high, and it is similar in India as the globally. And the biopsy confirms celiac disease also about 0.68%. So the incidence of celiac disease is about 12.9 per lakh of adults. And also he talked about expanding clinical spectrum. So the celiac disease not just present with the chronic diarrhea, they present with hematological manifestation, cutaneous manifestation, hepatic manifestations, endocrine, dental, and so many other manifestations. He told that 1 in 31 patients of iron deficiency anemia have celiac disease. 1 in 7 cryptogenic cirrhotics also have serology positive for celiac disease. And then he talked about diagnosis of celiac, which is biopsy-free. So biopsy-free criteria, which is published by Espagan in 2020, where patients either symptomatic or asymptomatic who have anti-TTG above 10 times and who have EMA positive can be diagnosed without the biopsy. But there are challenges because of the TTG serology used. And he also talked about newer biomarkers like low plasma citrulline can predict villus atrophy. And he told that a virus can trigger celiac even in adults. And he talked about novel treatment for celiac like latiglutenase, larazotide, and HLA blockers, which are in preclinical phase or phase 1 or 2 trials. And he also talked about animal models of celiac. The next talk was by Dr. Rupa Banerjee, where she told that in fact we human beings are more bacteria than actually humans. She talked that the factors which affect the gut microbiome are not just genetic, birth root, geography where the person resides, hygiene, and stress factors, and many other factors. She talked about difference in microbiome between obese individual and normal individuals. And she talked also about a PROTECT trial where patients with children with ulcerative colitis, where microbacter actually predicted the response. Then she talked about a future concept where diet would be the best medicine and not the general medicine. And she talked about future of the microbiota, which would be in terms of liver therapy and in terms of next generation FMT. And food is the best medicine. She ended her talk by this. The next talk was by Dr. Ajit Sood, who talked about fecal microbiota transplantation. The strongest evidence is for the recurrent C. difficile infection, where the cure rates are more than 90%. Then he talked about FMT for IBD, where it could be used for induction of remission in mild to moderate ulcerative colitis. There were 4 randomized controlled trials which achieved a 38% remission, and 3 of those 4 trials were positive. He talked about Indian experience, especially his own trials of in IBD, induction of remission, maintenance of remission, then factors influencing response to FMT, and acceptability of FMT, which is more than 80%. He talked about FMT for irritable bowel syndrome, which has given only mixed response. And then he also covered briefly about FMT for liver disease, especially alcoholic hepatitis, where 2-3 trials are there from India. And then he talked about future of FMT, which could be capsules, FMT capsules, or even selective microbiota transplant. Then the last talk was by Dr. Barham from Mayo, who covered the non-surgical weight loss strategies. He told about why Indians and especially Asians have such high risk of heart disease even at a lower BMI. He told that these Indians they are thin from outside but actually fat from inside because of visceral obesity. And then therapeutic goals was to improve insulin resistance, decrease visceral adiposity, decrease inflammation, and restore mitochondrial function. So he told the weight loss success with diet and exercise is in combination is better than diet or exercise alone. And but none of the diet or exercise can achieve a 10% weight loss. He talked about the drugs like orlistat, phentermine, naltrexone, bupirenone, and liraglutide. And the best response is again with phentermine, but still the response rate is less than 10%. Then he talked about endoscopic therapies, which like space occupying devices like balloon, which can achieve a 10% of weight loss. Then he talked about gastric remodeling procedures, then endoscopic suturing devices, which can actually achieve a weight loss of 17% and which can be maintained for up to 5 years. Then he also talked about aspiration therapy, and all these endoscopic therapies can achieve 10% of weight loss in up to 60 to 70 or even 80% of patients. Then he also briefly covered weight independent pathways which target duodenum, which actually drives the insulin resistance. So there are bypass devices like endobarriers. Then there are ablative techniques, which could be laser ablative, thermal ablative, and non-thermal ablative resurfacing technique like electroporation. And then he also talked about the endoscopic anastomosis using magnets. And in the last, he said that the future is combination of all these therapies. So this is what we learned today. Over to Dr. Arora. You can cover if I missed something.
Yeah. Thank you, Ashish. I think you have done a wonderful job of summarizing what we have learned today. I'm thankful to Professor Anand, Professor Abudai, and all the panel members for having enlightened us on the topic of non-surgical weight loss management strategies. And with a tribute to the speaker, moderators, and the panel members of all the sessions today, we had 3,800 people who had logged on to listen to your talks. I do agree with Dr. Anand that we had a delayed gastric emptying. We ended 1 hour later than what we should have done, but I think it was a treat for all of us to have heard you all speaking giving such good presentation on the current concepts in management of various luminal gastrointestinal disorders. With that, I thank everybody, including the sponsors of the meet, especially Mr. Pranav, and everybody who has joined. And we hope to see you next Saturday around 6 p.m. to discuss about the newer advances in diagnostic endoscopy. With that, it is goodbye and good night from all of us. Thank you so much.
Thank you, sir.